hope I'm audible now. Very good morning, very happy morning. Seeing you after some gap. Happy morning. And I know things are going with kuncham ups and down. Huh? Well, that's life. No worries. So the plan is today we have 2 days zoology class, and we planned it like this, that class 11th syllabus we will be doing. I hope my voice is coming clearly. Voice is coming clearly. Anyone can just say yes. Voice coming clearly, bachcho. Achar. Okay, right. Done. So the plan is this, that we will be completing class 11th today, and then class 12th will be done tomorrow. Yesterday, I have taken a poll also from the students of the Telegram who are connected to me. So we have made 2 type of plan. So this was plan A and this is plan B. Most of them have only voted for plan A. The only difference in plan A and B is that the plan A would get over by 12 because we started 15 minutes late. So maybe by 12:15, the plan A will get over. The plan B was getting over by 1:30. So that was the only difference of 90 minutes. Okay. If we require, we can give miscellaneous time in the last for some points which I come across. Okay. So we will start with the human physiology part. And I thought of starting with the structural organization, which was my plan earlier, that cockroach I will start with, because cockroach is something which you people have forgotten. But I will give cockroach to the time when your energies are very, very high. So right now we start with the very basic topic, which is like most of you have good knowledge about. Just a quick revision of the things required. So breathing and exchange of gases, okay? So this is how the timing have been decided for all the classes, okay? So just we got delay by 15 minutes, so I will plan accordingly, okay? Right. So shall we start now? Okay. Now in this chapter, most questions come from the spirometry. I hope you understand about spirometry. It is a pulmonary function test. Spirometry, and I've seen many questions are coming from it. So the normal volume of air which we inhale and exhale during normal breathing is known as tidal volume. Which volume? Tidal volume. And the value for tidal volume is about 500 ml, which is half a liter. This is so this is how the spirometry is being done. Okay, so let's start the play first, current page, right? Okay, bacho. And the report will come in this manner. So this is how the report will come, like this, in the form of a graph. So this is the volume which we inhale and exhale during normal breathing, and that is called tidal volume, which is half a liter. Now when we inhale deeply, when we inhale deeply, we inhale some extra volume of air. The extra volume of air that we inhale by forced inspiration, or that we can maximum inhale, is maximum inhale or by forced inspiration. Both are same thing. By forced inspiration or how much we can maximally inhale. Both means the same thing, right? So this is known as inspiratory reserve volume, and this is the inspiratory reserve volume, and this is about 2500 ml to 3000 ml. Makes sense, right? About 2.5 to 3 liters. Then the volume of air we can exhale maximally. So the surplus volume, the extra volume of air that we can exhale maximally, is simply called expiratory reserve volume. inspiratory, this is expiratory, same. And this was the tidal volume, which is about half a liter. Expiratory reserve volume for my student, I always give 1 liter, which is about 1000 ml. Okay. So although it is 1100, but you can take it 1000 ml because even the medical book says 1 liter only. So that will answer your questions. Then, when we maximally exhale, we know that some volume of air is left in the lungs. And you all know that volume is known as residual volume. And can you tell me how much is that volume? And that volume is about 1200 ml. How much? 1200 ml, right? So that is called residual volume. So these are the 4 pulmonary volumes that we check for, testing the pulmonary function test or the lung function test. But so this is the residual volume. Makes sense? Right? And this is how much? It is about 1200 ml, 1.2 liter. This was about 500 ml, and this was about 2500 to 3000 ml. Now, the capacities. Capacities means we have to add and get the. We have to add. Thank you so much. So the capacities. The capacity means the total volume of air we can inhale maximally. The total volume of air we can inhale maximally is known as inspiratory capacity, because this is the sum of tidal volume and inspiratory reserve volume. We have to just add both of them, which become 3000 ml to 3500 ml inspiratory capacity. But in our NCERT book, similarly, they have given something called expiratory capacity. In clinical practice, we don't have anything called expiratory capacity, but there is similarly, they have given expiratory capacity. Expiratory capacity means just add tidal volume and expiratory reserve volume will get expiratory capacity. Okay, bacho? Right. Now, another way of saying the inspiratory capacity, now listen very carefully. Another way of saying the inspiratory capacity is the maximum volume of air we can inhale after based on the measurements which are made directly by spirometry. So in any capacity, if you have residual volume, that capacity cannot be measured directly by spirometry. So what are those? Yes, think of. That is number one, that is called functional residual capacity, because this includes the expiratory reserve volume and residual volume. You cannot measure this capacity by spirometry. Another one is the total lung capacity. Total lung capacity, which also includes that we cannot measure directly by spirometry. Do you think any other capacity that we cannot measure directly? Any other capacity which includes the residual volume? Well, there is no such capacity which includes the residual volume. One is this one and one is this one. These are the two capacities. This is the functional residual capacity and this is the total lung capacity. We cannot measure directly. And of course, because both of them include this volume and this volume. So when they ask about the volume, you can say residual volume. And when they say that what are those capacities, which is based on measurements made by spirometry directly. So you can give these are the two capacities. I hope, Bacha, this is clear to every one of you. And well, Bacha, this is the, the labeling in the diagram. Okay, now, another way, another place where the questions can come is the mechanism of breathing. In mechanism of breathing, you should know that we have inspiratory muscles. The inspiratory muscles are diaphragm and external intercostal muscle. The diaphragm contracts, increase the length of the thoracic capacity, thoracic cavity. So it will increase the volume of thoracic, thoracic cavity in anteroposterior dimension. AP, this is anterior, this is posterior, anteroposterior dimension. when the external intercostal muscle contracts, you know that this brings the chest outside and upwards. So it brings the sternum outwards and upwards. So it will increase the dimension of dorsoventral dimension. It also increases the volume of thoracic cavity in dorsoventral axis. So both of them increase the volume of thoracic cavity. You know that the anatomical setup of lungs in thorax is such that any change in the volume of thoracic cavity is also reflected in the lungs volume. I repeat, anatomical setup of lungs in thorax is such that any change in the volume of thoracic cavity is also reflected in the pulmonary cavity. Right? So if the thoracic volume increase, the lungs volume increase. And by applying the Boyle's law, you know that if the lungs volume increase, the pressure inside the lungs decrease. And the moment the pressure in the lungs become lesser than the atmospheric pressure, the air gets in, right? So these are the two inspiratory muscles. Now, when these muscles relax, they will again increase the length. So when the muscle relax, okay, so when the diaphragm relax, it will become dome shaped, and when it becomes dome shaped, this dimension decreases, and when any dimension decrease, the volume decrease, and when the volume decrease, the pressure inside increase, and the moment the pressure inside the lungs become more than atmospheric pressure, the air comes out of lungs. Air move according to the pressure gradient, but air in the lungs, in and out of the lungs, or the blood in the body, in the blood vessels, all movements are due to pressure gradient, means from high to low pressure, right? So when the diaphragm contracts, it becomes dome shaped. It decreases the volume of thoracic cavity and also the lungs cavity in AP axis. Similarly, the external intercostal muscle, when it relaxes, it will again bring the sternum downwards and backwards. So it decreases the dorsoventral axis. When any axis decrease, any dimension decrease, the volume decrease and the pressure increase. And when the pressure increase, the air goes out of lungs. So this is how the mechanism of breathing takes place. Now, please note down this important point here, which is given in this bold or this, colored line. Abdominal muscles, additional muscles provides ability to increase the strength of expiration and inspiration, right? So we can increase this, we can increase the inspiration, we can increase the expiration. We have seen, right? When we deeply inhale, we can increase deep inspiration, we can do force inspiration, and similarly we can do force expiration, right? So when we do the force inspiration, the same external intercostal muscle is working more. Actually, for the normal inspiration, the main work is done by the diaphragm, okay, and very small work done by the external intercostal. Now, when you have to inhale deeply, then the external intercostal is working fully, and when external intercostal works fully, diaphragm works fully, we can inhale fully or maximally. Right. But what about the maximum expiration? When we have to exhale the extra volume of air, then we require two additional muscles. And these are number one, internal intercostal muscle, and number two, abdominal wall muscles. Abdominal wall muscles. When these muscles contract, what will happen? The volume of the thoracic cavity and of the lungs decrease further, and when the volume of the lungs decrease further, the pressure inside the lungs increases further, causing the air to go out of the lungs further. That means extra volume, and this causes this additional volume of air that we can exhale maximally. So these are the two muscles which are only required during forced expiration. For normal expiration, we don't require any muscle contraction. And since we don't require any contraction of any muscle, we can say that the normal expiration is just a passive process. It is a passive process. I hope it makes sense, right? Passive means it does not require any muscle contraction. But I think you are getting the things by the pace which I am maintaining and also the explanation which I am doing right now. Are you getting the things, or any special thing that you require? Any particular places you require that only this one, that one? You can tell me. Okay. Are you getting the things fully? Perfect. Perfect. Fully. I'll just discuss one more point which is very, very important in this chapter, and that is the regulation of breathing. Okay, so you are getting the things, and this is like really rebrushing your memory. Okay, done. I can take your comments. Fine. Now, I'll come to the regulation of breathing. The regulation of breathing is done neurally as well as chemically. The neural regulation is done by two places. Number one, respiratory rhythm center. And where it is located? Yes, where? Medulla oblongata. Another center is called pneumotaxic center. And where it is located? Where? In the pons varoli. So these are the two centers which control the breathing, right? So this is a neural control. The rhythm center sends signal to contract the inspiratory muscles. Which are those inspiratory muscles? Can you tell me? Yes, which one? One is diaphragm, other one external intercostal muscle. Perfect, right? So these are the inspiratory muscles. And who send the signal to them? The rhythm center of medulla. The pons center, which is pneumotaxic center, can control the rhythm center. How? It can switch off. It can switch off the rhythm center. So what it can do? It can decrease the duration of inspiration, because the moment it switches it off, the inspiration stops. And when the inspiration stops, then what happens? Expiration. Right. So if your pons center, the pneumotaxic center, is working 15 times, it is sending signal 15 times in 1 minute. So how many times the inspiration stop in 1 minute? How many times? 15. So how many inspiration? 15. How many expiration? 15. But then, if due to some change, if the pons center sends signal 20 times in 1 minute, that means it switches off the rhythm center 20 times in a minute. Frequency fast ho gaya uska, right? Then how many inspiration? 20. How many expiration? 20. Right. So pons center not only decrease the duration of inspiration, but can also control the rate of breathing. So what are the functions of the pneumotaxic center in the pons? The pneumotaxic center of the pons control the duration of inspiration and rate of breathing. I just now told you. If it fires 20 times a minute, the rate of breathing, how many inspiration? 20. How many expiration? 20. Rate of breathing? 20 per minute. Right. So its frequency can determine the rate of breathing. This is the function of the pontine या pons का center. So बच्चा, these are the neural control. That's it. अच्छा. Remember, very, very important, which I think some of you might be confused about, both these muscles, external intercostal and the diaphragm, these are voluntary muscles. That means you can control them voluntarily. Yes, so even the cerebrum can control them. Let's try. Okay, let's contract diaphragm and EICM. I control them. Why? Because they are voluntary muscles. Yes, so they are also controlled by the cerebrum. So these are all neural control. Subconsciously, they are controlled by rhythm center, which is in the medulla oblongata, and the rate of breathing and the depth matlab duration, kitna gehra, the depth of breathing, the depth of inspiration is controlled by pons center. Right. But our breathing is also controlled by CO2 and H plus ion concentration of the arterial blood, percentage saturation of hemoglobin, and all the other variables are kept constant. So what are kept constant here? One is carbon dioxide, one is the acidity or the pH of the blood, and one is the temperature. I call them cat manipilli. I call them cat, okay? So chudu, cat, C-A-T, cat. Now, what happens, beta? During exercise, when you work more, when the muscles are working more, then your cat increase. What increase? Cat increase means carbon dioxide in the body increases. Whenever the CO2 increase, the acidity of the blood increases. Always remember, because CO2 is very much soluble in water, and CO2, okay, because it is soluble in water, it forms carbonic acid. Which one? Carbonic acid, an acid. So acidity of the blood increases, and when the body works more, temperature of the body increases. So that's why I say, whenever you are exercising, your cat increases. And bacho, when your cat or carbon dioxide acidity temperature increases, then this curve shifts towards the right side, which means that now the dissociation is more. Chudandi. Earlier in the veins, how much oxygen is? 75% saturated. Hemoglobin is 75% saturated. And now you can see in the same blood, it is less saturated. Okay, in the same blood, it is somewhere right side, it is even less saturated. And you can see this can go up to 25. So all this happens, this is all between this and this can happen depending upon how much CO2, acidity and temperature increase. But this is the maximum limit. And what is the maximum limit? This, which means that 25%. The blood can never be less than 25% saturated. The hemoglobin of the blood can never be fully empty. Always 25% saturation is there, even in vigorous exercise. If you think won't we die? No, it's enough. Our body is okay, this is maximum. We don't require this much also. See, 25% or 5 ml is okay for us. Okay, sometimes we may require 6 ml, 7 ml, 8 ml, 9, 10, 11, but we can get up to 15 ml. Every 100 ml can give how much? Up to 15 ml. That is more than what we require even during vigorous exercise. I hope bacho you increase. So whenever the CO2 acidity and temperature increases, the oxyhemoglobin dissociation curve shift toward the right side. Now bacho, a question comes that, and what is that question? Let me tell you. The question is, on what conditions the saturation of hemoglobin depends. So it depends primarily the saturation of hemoglobin saturation depends primarily on PO2. More the PO2, more will be the saturation. It also depends on carbon dioxide. Lesser the carbon dioxide, more will be the saturation. It also depends on the acidity. So lesser the acidity, more will be the saturation. It also depends on the temperature. So lesser the temperature, more will be the saturation. Okay. So these are the 4 variables. This is the primary one, and these can affect. Okay. So this is the primary on which the saturation depends, and these can affect. When CO2 acidity temperature increases, the saturation decreases. Okay. Now, if I compare this to carbon dioxide, so the hemoglobin binding to carbon dioxide depends primarily on PCO2. It is related to PCO2, no problem, but it depends on PO2. In fact, it mainly depends on PO2. Again, what I am discussing about, this is oxygen over. I am discussing about carbon dioxide, saturation of hemoglobin with carbon dioxide. It is related to PCO2. Obviously, more CO2, more saturation, but it is mainly dependent on PO2. So if the condition is more CO2, less O2, more binding. Reverse, less CO2, more O2, less binding. So always remember that if the O2 is more, the binding will be less and dissociation will be more. Where is this more O2? More O2 can be seen in the lungs. So when the blood reaches the lungs, the binding of hemoglobin and carbon dioxide decreases because in the lungs oxygen is aqua, more. So the binding affinity of hemoglobin and carbon dioxide decreases. And what happens in the lungs? Yes, dissociation. In the lungs, dissociation of carbon dioxide occurs. So you understand how important these characteristics or properties are, and they are actually making our lives possible. But if we are just knowing 0.001% of them, I don't know what is that 0.000 fraction, what we are learning. But every point that we learn really fascinates us. And whenever the paper setter make a paper, these also fascinate the paper setter. And since these points are given in the NCERT book, the paper setter has all rights to give them in the examination. So you can get this question, pakka question, okay? Every 100 ml of the oxygenated blood, every 100 ml of the oxygenated blood delivers 5 ml of oxygen to the tissues. 5 ml of oxygen to the tissues. Okay, so this is oxygenated blood. How much? 5 ml of oxygen to the tissues. Now, every 100 ml of deoxygenated blood, every 100 ml of deoxygenated blood delivers 4 ml of CO2 to the lungs. 4 ml of CO2 to the lungs. In the tissues, the O2 is less, CO2 is more. So what about the binding? Come on, tell me, what about the binding? Binding will be more. Binding of carbon dioxide with hemoglobin will be more. In the lungs, O2 is more, CO2 is less. So binding will be less, and when the binding is less, the hemoglobin, this breaks from hemoglobin and carbon dioxide, it will go to the lungs, and that's how we exhale it out. Okay, bachcho, so that's about this topic. Okay, well, let's now start body fluids. I hope you understand this topic. Main points I have discussed, whatever I think the examiner, is very fascinated about for making. Number one, the spirometry, the values, okay, and number two, regulation of breathing, mechanism of breathing. We also discussed the muscles of breathing, and finally we discussed, okay, the hemoglobin saturation with oxygen as well as with carbon dioxide. 99% I find these questions, and what I expect that around 3 questions in the paper are expected from this chapter. We started with a 15 minutes delay, and almost at the right time, we have finished off this chapter. I'll again show you the plan so that in your mind also, the plan should be ready that what we are doing and what is now about to come. So this was the plan we are following. The official timing was 7:30. So 7:30 to 8, ideally I kept it for this chapter. Okay, so we started around 15 minutes delay, and with a plus minus of 5 minutes, we have almost finished it. So this topic is over. Now the next topic is body fluids and circulation. Again, I will be now focusing on main areas where I can expect the questions in body fluid and circulation. So number one, body fluid. What are the two body fluids? Number one, blood. Number two, lymph. And then the circulation, wherein we have to discuss about the cardiac cycle. And also here the disorders are also important. In body fluid and circulation, disorders are also important. Breathing and exchange of gases, disorders are very simple. Okay. So here, body fluid and circulation, disorders to be explained. Let's begin this topic. for our guiding, and also we will also see the diagrams that are there. This is a body fluid topic. So starting with the main body fluid, which is the blood. In the blood, blood is a connective tissue. Just like any other connective tissue, it has got cells and matrix. The cells are called formed elements and the matrix is called plasma. The plasma constitutes 55% of the total blood volume, and the formed elements altogether, packed cell volume, it constitutes 45% of the total blood volume. So formed elements volume, how much? 45%. Plasma, which is the matrix, fluid matrix, how much? 55%. Makes sense? Till here, points clear. Very good. In the plasma, we have got the water 90 to 92%, protein 6 to 8%. In the proteins, we have albumin, globulin, fibrinogen. Remember, the globulin is the same antibody. The antibody is also a globulin protein. Fibrinogen is a plasma, it's a clotting factor. It is the first clotting factor discovered. So we call it clotting factor number first. The albumin is responsible for colloidal osmotic pressure. The nutrients are glucose, amino acids, and lipids. Okay, and the minerals are these minerals. Okay, factors of coagulation or clotting of the blood are also present in the plasma in an inactive form. Now, the formed elements are RBCs. The normal RBC count is 5 to 5.5 million per cubic mm. Always remember, bacha, the blood counts are given in per cubic millimeter. Always remember, the blood counts are given in per cubic millimeter. Any other value is given in per 100 ml of blood. For example, how much we have, I'll make it play here so that ये थोड़ा हिलेगा नहीं. ये हो रहा ना प्रॉब्लम, ये नहीं होगा. इसको करंट पेज, हाँ, right. So how much is the RBC count? 5 to 5.5 million per cubic millimeter. And how much is the hemoglobin? Hemoglobin is how much? 12 to 16 grams per 100 ml of blood. I told you, any other volume or any other value per 100 ml, only the counts, blood counts, because the device that we use to count, that is called hemocytometer, it can only give the values in per cubic millimeter. Therefore, we always give in per cubic millimeter. Let us compare the counts. RBC count done. What is the total leukocyte count? Yes, how much? 6,000 to 8,000 per cubic millimeter. What is the platelet counts? How much? 1.5 lakhs to 3.5 lakhs per same cubic millimeter. Malli, 5 to 5.5 million, 6 to 8,000, and how much? 1.5 to 3.5 lakhs platelets. Okay, these are the blood counts. Also, we discussed about the hemoglobin. How much was that? 12 to 16 grams. Okay, and plasma proteins we discussed. Then the WBCs, we have two types of WBCs. We have granulocytes and agranulocytes. The granulocytes, also known as the PMNL, polymorphonuclear leukocytes, are neutrophils, basophils, eosinophils. Neutrophils, basophils, acidophils. The acidic stain or the dye is eosin. Mainly we use eosin in hematology lab. So actually the convention becomes that acidophils become eosinophils. The basic dyes, we use two basic dyes, okay, and the neutrophils are neutral to the pH of the dye, so the coloring doesn't depend on the pH of the dye or the stain. So neutrophils, basophils, eosinophils. The agranulocytes are monocytes and lymphocytes. Now, in the order of decreasing order, maximum WBC are neutrophils, 60 to 65%, percent of the total leukocyte counts, followed by lymphocyte 20 to 25%, followed by monocyte 6 to 8%, followed by eosinophils 2 to 3%, followed by basophils, base per, bottom per, base per, basophils 0.5 to 1%. So this is called differential leukocyte counts. Okay, bacha? Make sense till here? Points clear? Of course, I was just giving some warm-up points to you. Now I'll come to a point: coagulation of blood or blood clotting. Okay, so blood clotting, a clot is actually made up of fibrin mash. Fibrin is a protein. It is an insoluble protein. Which protein? Insoluble protein named fibrin. It forms a mash. Okay, you know that the cotton yarn or any polyester yarn matlab thread, daga. Okay, so that forms a mash, and that mash makes this apparel, the cloth. Cloth is actually a mash of yarn. Same, the fibrin mash forms the clot. And why it looks reddish or brownish? Because the blood cells are trapped in it. And which is the main blood cell? Which is the 99% blood cell? RBCs, 5 to 5.5 million. So they are trapped, and that's why it looks dark brown or reddish in color. Okay, so fibrin. Now, fibrin is actually present in our blood, but not in the fibrin form, in its inactive form, fibrinogen, which is a soluble protein. It becomes fibrin, it becomes insoluble. Fibrinogen is moving normally in our blood, where that 6 to 8% wala tha na, 6 to 8% plasma proteins wala usme, right? So fibrin is there in the blood. It is activated by one enzyme known as thrombin. Which one? Thrombin. So thrombin, this enzyme, and also calcium ions, which is an inorganic cofactor. Enzyme requires cofactor. So calcium ions and thrombin converts fibrinogen to fibrin. From where this thrombin, calcium तो हमारे blood में है, minerals बहुत सारे हैं. From where this thrombin comes? Actually, thrombin was also present in the blood only, but in its inactive form, prothrombin, right? And prothrombin is activated to thrombin by an enzyme complex, Peru thrombokinase. Now, this thrombokinase is not a single clotting factor. It is made up of two clotting factors, 10 and 5, right? So it is the activated clotting factors. So basically, we can call it as an enzyme complex. So conversion of prothrombin to thrombin depends on an enzyme complex, thrombokinase. This enzyme also requires calcium ions as inorganic cofactors. Thrombokinase, from where this is formed? Actually, thrombokinase is formed by a series of reactions, and these reactions are popularly known as the cascade reactions. A cascade reaction is the one where the end product of one reaction becomes the reactants of the next. Okay, it's just like a dominoes effect. You know dominoes effect? Many bicycles in the bicycle stand, you just push one bicycle, cut, one by one, and maybe 100 bicycles are there. You don't know that you have actually made that 100 one also fall, all the 101 fall, just by pushing one bicycle. Same, just by activating one clotting factor, all the other clotting factors gets activated by themselves. Again, cascade, cut, dominoes effect. So this thrombokinase is formed by series of reactions. Yes, two pathways make thrombokinase. But one pathway is intrinsic pathway, which begin from the platelets factors which are released from the platelets. The other pathway begins from factors released from the injured tissues. So one released from the platelets, factors released from the platelets, and the other one begins from the factors released from the injured tissues. Injured tissues. This is called intrinsic pathway. This is called extrinsic pathway. And the cascade reaction. Okay. So both of them ultimately form thrombokinase. Thrombokinase. And what this thrombokinase can do, thrombokinase along with calcium cofactor can convert prothrombin to thrombin. What the thrombin can do, thrombin can activate fibrinogen to fibrin. Fibrin, which is a insoluble protein. It's a polymeric protein like a thread, insoluble polymeric protein. And this forms a mesh, which is a clot. Okay. And here also the calcium ions are required as an inorganic cofactor. And remember, bacha, these all are clotting factors. So what are the clotting factors so far you have heard? Number one is called fibrinogen, which is the first clotting factor. Okay, then fit pants. Prothrombin. The second one is prothrombin, the second clotting factors. The third one is thromboplastin, which is actually released from the injured tissues. Okay, so thromboplastin, the third clotting factor. And the fourth clotting factor is the calcium ions. Calcium ions. So this one is the fibrinogen. This one is the prothrombin. This is that, I'll just write here tissue factor. ऐसे लिख देता हूं मैं, ठीक है? Tissue factor. So these are the four clotting factors that we have discussed. We have not discussed all these factors here. In total of 1 dozen clotting factors are required. Just remember this much. Now, bachcho, also remember something called the anticoagulants. So what are the anticoagulants? You know, number one, EDTA. What is EDTA? Ethylene diamine tetraacetic acid. Another one, citrates. Yes. Citrates can capture your calcium ions, and anything which can capture calcium ions can stop the clotting, because you know calcium ions are required as inorganic cofactors. What else? Low temperature. Yes, the blood in the blood banks is stored at 4 degrees Celsius. How much? 4 degrees Celsius. And this temperature is good because it can prevent the clotting. Right? So these are the anticoagulants. And do you know any natural anticoagulants? Yes, one of them is heparin. Can you tell me which blood cell releases heparin? Yes, I didn't hear. What is the name? Yes, you said right. It is basophils. Basophils. Can I ask you which cell in the areolar tissue release the same heparin? Yes, which one? Yes, mast cells. So mast cells and very good. Basophils and mast cells, they have the same origin and they secrete the heparin. Another one, hirudin. Where is this hirudin? In the blood-sucking leech. An annelid, leech. Very good. In the blood-sucking leech. Very good. Any other one you have heard? Anopheline. Anopheline. Where is that? In the saliva of female mosquito. Anopheline in the saliva of female mosquito. Anyway, that. Okay, so these are the clotting anticoagulants that one should know. Now, the blood grouping is based on the two antigens present on the RBCs. Okay, antigen A and antigen B. The 4 blood group, the 4 phenotypes and 6 genotypes. And you know all this thing. Please remember that the universal donor is O blood group ORH negative, and the universal acceptor is ABRH positive. Now directly we can come to the cardiac cycle. The cardiac cycle is a series of changes in the two chambers, atrium and the ventricles, which forms one heartbeat. So from the beginning of one heartbeat to the beginning of the other heartbeat, all the changes which happens in the heart. You know that the heart of crocodiles, alligators, gavialis, ghadial, alligator, crocodile, gavialis, ghadial, birds, mammals, all these hearts are how many chambered? 4 chambered heart, 2 atria, 2 ventricles, okay? And they have got completely double circulation. One circulation is called pulmonary circulation, the other one is called systemic circulation. Which is the pulmonary heart? The right side of the heart is called pulmonary heart. What is systemic heart? The left atrium, left ventricle is a systemic heart. That also you know. Fine. Okay. Now, Just let's try to understand the cardiac cycle. The cardiac cycle begins from the impulse generated from SA node. What is SA node? Sinoatrial node. Sinoatrial node can generate action potentials. Okay, where is this located? It is located on the right upper corner of the right atrium. Where? Upper right corner of the right atrium. Upper right corner of the right atrium. Okay, and it generate action potential, and it can contract both the atria together. Where both the atria contract together, it takes about 0.1 second to complete the atrial systole. Contraction is called systole, relaxation is called diastole. Contraction called systole. In systole, the pressure inside the chamber increase and the blood ejects out. In diastole, the pressure inside the chamber decrease and the blood fills in. Systole, blood pumps out. In diastole, blood fills in. So atrial systole lasts for 0.1 second. The total heartbeat lasts for 0.8 second. So 0.1 second is atrial systole. The remaining time is atrial diastole. What is the time? 0.8 minus 0.1. How much? 0.7. 0.7 second is atrial diastole. The ventricular systole occurs for 0.3 seconds. And the remaining time 0.5 seconds is ventricular diastole. Always remember that there is always a delay between atria and ventricles, which means that they cannot go in systole together. Once again, remember, atria and ventricles cannot go in systole together. And this is very critically maintained by something known as AV node, atrioventricular node. Where is this located? Lower left corner of the right atrium. Where it is located? Lower left corner of the right atrium. What is the name? AV node. The AV node is a speed breaker. It can slow down the impulses for 0.1 second. So the ventricles contract only after 0.1 second of the beginning of the atrial systole. Remember that heart is just one muscular organ, and muscle cells are conducting cells. So if action potentials are generated, which are nothing but the potential difference, the entire heart can become depolarized and the muscle can they go into systole. The muscles can contract. But remember, there is a very strategic design so that the atria and ventricles are electrically separated, and this separation is done. Atria and ventricles are electrically separated by thick fibrous atrioventricular septa. The atrioventricular septa. Why I am calling septa? Because right side and left side, so two are there. I am using the plural word. Atrioventricular septa is thick and fibrous one. So it separates atria and ventricles. So the only electrical continuity between the atria and the ventricle is through a bundle of fibers arising from AV node. This bundle of fiber is very, very strategic. This bundle of fiber pierces the atrioventricular septum and emerge on the top of the interventricular septum and immediately there itself divide into two, okay, bundle branches. I repeat what did I just now said. The diagram also says the same thing. This is the AV node. From the AV node, a bundle of fibers arise. This bundle of fiber, this pierces the AV septa, and it is the only electrical continuity between the atria and the ventricle. It pierces the AV septa and emerge here on the top of the interventricular septum. And the moment it emerge, it divides into two bundle branches. The right bundle branch and the left bundle branch. Each bundle branches will further give so many branches to go to each and every part of the myocardium of the ventricle, and these fine fibers which go to each and every part of the myocardium are known as Purkinje fibers. So this entire thing that you see in the diagram, which is yellow in color, is called the nodal tissue. Why I am calling it a nodal tissue? The name nodal tissue is given because it was first found in the nodes. Which node? The SA node and the AV node. The SA node is sinoatrial node. In our ancestors, the sinoatrial node is present on the sinus venosus. But what happens that the sinus venosus of our ancestral heart that become merged with the wall of the right atrium in the mammals. So the SA node has now come on the wall of the right atrium. So it is found upper right side of the right atrium. and the AV node lower left side of the right atrium, upper right, lower left, upper right, lower left. From the AV node arise AV bundle. AV bundle emerge on the top of the interventricular septum and divide into two bundle branches. And the bundle branches give many Purkinje fibers. Now you must be thinking, sir, how these two are connected? No need to connect, because this all is very, very, conducting. The muscle cells are very conducting, right? They are excitable cells just like the nerve cells. Okay. Now, one more thing about the septa. One septum is atrioventricular septa. This is thick and fibrous. Another septum is, you can see here, interventricular septum. This is thick and muscular. Thick and fibrous, thick and muscular. But another septum is between the two atria, and this is thin and muscular. So between the atria, interatrial, thin muscular, interventricular, thick muscular, atrioventricular, thick fibrous. Make sense? Understood? Very good. This is a nodal tissue. Every part of the nodal tissue can generate action potential. Yes, it is excitable. It is auto-excitable, in fact. Not only excitable, it is auto-excitable, the nodal tissue. If you just separate them, this, you can separate them and keep them separately. You will find that all can generate action potential. But whatever potential they are generating, the number of action potential they generate in 1 minute, or the rate of generation of action potential is not equal. Okay, some is generating about 70 to 75 times in 1 minute, some is generating about 40 per minute, some generating about 22 to 25 per minute, like that. So every place has different number of action potentials generated per minute. But when you connect all of them and make a complete circuit, you find that all this entire thing, this entire nodal tissue, this can generate action potential equal to the one which is generating the maximum. And we know that the maximum are being generated by the SA node, the sinoatrial node. It generates about 70 to 75 action potential in 1 minute. So when all of them are connected, just like in the diagram you can see, you will find that all of them are generating and conducting action potentials at the rate of 70 to 75 times per minute. And you find that the number of heartbeat in 1 minute are also the same, 70 to 75. If SA node changes the number of action potential, if suppose it changes the number of action potential to 80, you will find that the entire one is actually now making 80 action potentials in 1 minute. So, and all these atria and ventricle, their contraction and relaxation is how many times? 80 times. So the heart rate becomes 80. So you find that it is a SA node which actually determines the rate of the heartbeat. We can call the SA node as the pacemaker of the heart. This is called the pacemaker of the heart, and atrioventricular node can be called as the pace setter. However, this is not a very good term. I mean, it's a very good term, but not a very standard term. You'll not find that the moment you say pace setter, and you'll find that 100 scientists are saying, oh, AV node, AV node, AV node. Oh, some authors have described it as pace setter. Why? Because this can maintain a delay of 0.1 second between the atrial systole and the ventricular systole. I mean to say, the ventricle go in systole after 0.1 second of atrial systole. I repeat, the ventricle go in systole after 0.1 second of the atrial systole. Okay, so here is the diagram. As you can see, this is the atrial systole. Atrial systole is for 0.1 second. The ventricular systole is for 0.3 seconds. Okay, so total 0.1, 0.3. After that, you know that when the atrial systole is over, atria is in diastole. When the ventricular systole is over, ventricle is in diastole. So this is the time of joint diastole. Nearly half of the duration of cardiac cycle, as you can see, half of the duration of cardiac cycle, both the chambers, atria and ventricles, are in diastole. So we can call this as joint diastole. Joint diastole. Atrial diastole lasts for 0.7 seconds and ventricular diastole lasts for how many? 0.5 seconds. Make sense? Till here all points clear? I hope it is clear. Right. Now, cardiac cycle is the series of contractions and relaxation. It begins by firing of the SA node. When the SA node fire, atria go into systole. I think I have a diagram of the cardiac cycle. Let me show it to you. Yeah, this one. When the SA node fires, the atria go in systole. This is the atrial systole. When atrial systole occurs, the pressure in the atria rises and the blood from the atria go into the ventricle. Because of the atrial systole, the atrioventricular valve opens up and, this last line I am erasing. Please, sorry. Okay, so when the atrial systole is going on, the atrial blood is going into the ventricles. Okay, already you'll find that the atrioventricular valves are open. It is not the atrial systole which caused the opening. Already they become open. We'll just now discuss how they open, right? So now the atrial blood go into the ventricle, and now ventricles are completely full. So now the ventricular systole begins. Initially, there is no change in the volume, but this can increase the pressure so that the blood cannot go into the atria, and to prevent that, the atrioventricular valve, which is tricuspid and bicuspid valve, they close suddenly, and when they close suddenly, it produces a sound, and this is the first heart sound, S1, or the lub sound, the first heart sound or the lub sound. Make sense? Okay. Right, and this is due to closure of the tricuspid and mitral valve. Now what happens that when the pressure in the ventricle rises more, you will find that there is an opening of the semilunar valve. The aortic and the pulmonary semilunar valve open up and ventricular blood ejects into the arteries. Which artery? Pulmonary artery and aorta. Okay. Now this occurs for 0.3 seconds. How much? 0.3 seconds. As you can see, this duration is 0.3 seconds. What is the duration of atrial systole? This duration 0.1. This is 0.3. Okay, right. Now, bacho, after that there will be ventricular diastole. Now, ventricular diastole means ventricles are relaxing. When ventricles are relaxing, pressure in the ventricle is, yes, decreasing. Okay, when the pressure in the ventricle is decreasing, blood from all around are trying to come into the ventricles. Obviously, in the arteries, the blood is with very high pressure. So the arterial blood, to prevent the arterial blood to come into the ventricle, back into the ventricle, there is a sudden closure of the semilunar valve. Immediately at the beginning of the ventricular diastole, there is sudden closure of the semilunar valve. And this produces sound too, which is also called the dup sound. So the duration between lub and dup is 0.3 seconds only. Okay, right. Dup sound. Now the ventricles are relaxing further. Pressure in the ventricle is decreasing further. A time comes when the pressure in the ventricle becomes lesser than the atrial pressure. And when that happens, when the pressure in the atria becomes little more than the ventricular pressure, the atrioventricular valve open up, and the atrial blood, which was actually filling during the beginning of the atrial diastole, I told you that diastole is a filling phase, systole is a pumping out phase. So blood is already here. Blood is here. So this blood is also creating a pressure, and in the ventricle the pressure is falling because of relaxation. So when that happens, when the pressure in the atria become more than the ventricular pressure, the atrioventricular valve open up, and all this blood of the atria come into the ventricle suddenly all together. This is a rapid filling phase, and bacho, this is a passive filling phase. This is a rapid filling phase or the passive filling phase, which accounts for 70% of the ventricular filling. How much percent? 70% of the ventricular filling occurs during joint diastole. So what is the result of this atrial systole? Nothing, just remaining 30%. Remaining 30% of the blood in the ventricles come during atrial systole. Okay, bacha. So whatever the remaining blood in the atrial pockets that comes into the ventricle during atrial systole. So at this time you will find that the ventricles have fully filled. Okay, So this end diastolic volume in the ventricles is about 120 ml on an average, 120 ml end diastolic volume. During this ventricular systole phase, the blood that comes out of the ventricle is about 70 ml, which means that it is not the complete blood which goes out of the ventricle. If you just subtract 70 from 120, it becomes 50, which means that at the end of the ventricular systole also, there is 50 ml of the blood is present in the ventricles. This can be called as the end systolic volume. How much it is average? 50 ml. I'm giving you very, very important calculations. And diastolic volume is 120 ml and systolic volume is 50 ml. So the difference of that is 70 ml. 70 ml is the blood that is being pumped from the ventricle out into the arteries independently both. The right also pump out 70 ml, the left also pumps out 70 ml. But when we say out of the heart is only when it is pumped into the aorta. Because from the aorta it goes out of the heart and go to other parts of the body. When it goes into the pulmonary artery, it again comes back into the heart only. So it is not that out of the heart. Yes, but out of each ventricle, that is okay. That we can say that is a stroke volume. 70 ml is a stroke, matlab beat, per beat volume. So in one beat, in one heartbeat, 70 ml of the blood is being pumped into the artery. Which artery? Yes, aorta and pulmonary artery. Bachcho, after that, can you tell me how much is the blood filled in the ventricle during ventricular diastole? This is an open question to everyone. Let me see how many of you are answering, how many of you can answer. Haan ji bachcha. Haan, I'll share this PDF, don't worry. This is only for you only. Pakka promise, I'll share this PDF. During ventricular diastole, how much blood is filled in the ventricles? Hello? How much total ventricular filling? Beta, total ventricular filling is the same which ventricle eject out. कोशिका सहस्रा बच्चा 120 ml नहीं है क्योंकि 50 ml तो पहले से है. 50 ml is already present here. 50 ml, which means that only 70 ml is filled. That becomes 50 plus 70, 120 ml. And diastolic volume is 120 ml. Fine. But how much is filled in the ventricle in one heartbeat is only 70 ml. Bacha, the heart gives what it gets. How much it gives, how much the heart gives out? 70 ml. So how much it is getting? 70 ml. You know, the day it gets 75 ml, it starts giving out 75 ml. This is called Starling's law. So the very common saying in medical sciences is called the heart gives what it gets. If it gets, you find that it is giving out 70 ml, so it is pakka that it is getting 70 ml only because the heart gives out what it gets. I hope you understand. So beta, 50 ml is always present in the ventricles. Ventricles are never empty. There are columns in the ventricular wall, very, very irregular. Columni carni, muscles, muscular ridges are there. If I show you the picture, you don't realize, you don't like that picture. Arey sir, kya hai irregular? Yes, ventricular, inner ventricular wall is not a very plain wall, very, very irregular muscular ridges are there. In those pockets, in those columns, some blood is left. How much? 50 ml. Can you tell me how much volume of blood is filled in the ventricles during ventricular systole, during atrial systole, what ml of blood filled in the ventricles during atrial systole? Come on. After this question, I will stop getting the answers on the screen. I will myself answer you. So just now, who gave this answer? Jhansi Lakshmi, absolutely correct. 21 ml. Very good, Bacha. Very good. Acha, you guys are smart. Savira Reddy, Sati Savira, very good. 21 ml, very good. You got the point. ECG. The electrical activity of the heart. Such an easy thing. I don't know why people make it difficult. These all represents depolarization. Only electrical, it is a graph which only shows changes in the, the potential, membrane potential. Depolarization. The P wave indicates atrial depolarization. The QRS complex indicates ventricular depolarization. The T wave represents ventricular repolarization. Where is the atrial repolarization? Yes, it occurs in the atria, but does this machine can find it? No. This machine is unable to get it because it is happening somewhere here. And at that time, it is showing QRS complex, so it won't get that. Make sense? Okay, bacha. This is only showing the electrical activity. P, atrial depolarization, not systole. Because systole doesn't begin at that point. There is a small delay. The depolarization begins here, but systole takes little time. So atrial systole begins here. And bacha, this much time is 0.1 second. So atrial systole lasts till this time. Means that when the ECG machine is showing the R wave, at that time your atrial systole is over. And when it's over, ventricular systole begins. Ventricular systole takes 0.3 seconds. By that time, the T wave is over. So when your T wave is over, it looks like the ventricular repolarization wave is over. But that is the end of the ventricular systole only. This is the only point. If you read the NCERT very, very clearly, I think here also it is mentioned that the systole begins slightly later than the Q wave. From here the systole begins and it gets over by the end of the T wave. That's it. So at this point we get the sound one, the lub sound, which is due to closure of the tricuspid and the bicuspid valve. And this point we get the sound to the dub sound, which is due to closure of the semilunar valve. This duration is 0.3 second. This duration is 0.1 second. And this is only showing the electrical activity. But actual activity is little delay. That's it. This is only the ECG point that we should remember. Point number one. Point number one is the systole begins shortly after the Q wave. Q wave ends here. Thoda sa baad mein, here, systole begins. Which systole? Ventricular systole. And the systole is over when the T wave is over. The end of T wave marks the end of ventricular systole. Okay, beta? Done. Done. Not required to do the very simple thing, double circulation. Regulation of the heart. The cardiac center is present in the medulla oblongata. It can increase the heart rate and blood pressure. It can decrease the heart rate and blood pressure. For increasing the heart rate and blood pressure, the sympathetic nerve arising from that cardiac center go to only to the SA node. The sympathetic nerves can only modulate matlab only affect or change the SA node frequency. They cannot go directly, the nerves cannot come directly inside the heart and cause the contraction of the heart muscle. The heart muscle contraction is under the action potentials generated by the nodal tissue only. All these nerves are only terminating at the SA node. Makes sense? When the cardiac center has to decrease the heart rate, at that time the parasympathetic nerves, the fibers come from the cardiac center, they go to the SA node, and what happens? The speed of conduction of action potential decrease. So what happens? Heart rate decrease, and bacha, heart rate decrease. So cardiac output decreases because cardiac output is the product of stroke volume and the heart rate. If the heart rate decreases, cardiac output decreases. Parasympathetic decreases the heart rate and cardiac output, whereas sympathetic increase the force of generation of force of contraction of the the ventricular. It can increase the force generated by the ventricles during ventricular systole. So it can certainly increase the blood pressure. Sympathetic stimulation can increase the blood pressure. It can also increase the heart rate. So sympathetic can increase the heart rate, it can increase the blood pressure, it can increase the stroke volume, and therefore it can also increase the cardiac output. So sympathetic can increase, parasympathetic decrease, sympathetic increase. Sympathetic, fight or flight mode, fight or flight, stress, anxiety, heartbeat, duk, 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 duk. Palpitation, heartbeat become faster. At that time, blood pressure is also faster. Some people suffer due to high blood pressure only because they are always remain in anxiety mode. The doctor says, I am writing these medicines, Garu, but you have to decrease your anxiety. But the doctor never says how, because the doctor himself is in anxiety. More anxiety than the patient. So this how is something which is not written in the medical book. Now the medical books, now that they say about the yoga and meditation, yes, even the Harrisons write about yoga and meditation, but this is not that easy to control your emotions and anxiety. Some people, they have different level of chemicals. I mean to say, sympathetic increase the heart rate and blood pressure, parasympathetic decrease the heart rate and cardiac output. Sympathetic, parasympathetic nerves are being carried along with the vagus nerve. How the sympathetic nerves come? They come independently. But the parasympathetic fibers, they come with the vagus nerve. So sometimes if I say parasympathetic stimulation, you can easily say that it can decrease the heart rate and cardiac output. But if I just change my question, I say, what if the vagus nerve stimulate? Same answer. Vagus nerve ante parasympathetic fibers. See, parasympathetic fiber is a brake on the heart. Vagus nerve is just a brake on the heart. It always try to slow down the heart rate. If you cut the vagus nerve, the brakes are removed and the speed increases, the heart rate increases. If the parasympathetic supply or the vagus nerve is cut, the heart rate increases. So vagus nerve is just a brake. It keep a brake on the heart rate and blood pressure. Okay, bacha, this is sympathetic, parasympathetic. But there is a chemical which actually imitate the sympathetic stimulation. And can you tell me what those hormones are called? I'll give you the trick. I'll give you the hint. The name of those hormones begin with C. What are those hormones which are same as sympathetic stimulation? In fact, when the sympathetic stimulation occurs, then one of our glands near the kidney Yes, catecholamines, yes. One of the glands near the kidney, over the kidney, the adrenal medulla releases the catecholamines. Very good. Catecholamines, they are same. What the sympathetic does, catecholamine does. Catecholamine कौन से होते हैं बेटा? Epinephrine and norepinephrine. I hope this is clear to you. Now, very, very important. Heart attack, myocardial infarction, and what about cardiac arrest and heart failure? Actually, there is coronary circulation. Coronary arteries are the two main arteries arising from the aorta, and they supply oxygenated blood to the muscles of the heart. Remember, heart pumps blood to all parts of the body to supply oxygen to all parts of the body. But heart muscle also require oxygen. In fact, if your thigh muscle doesn't get the oxygen for some time, you can at least lie down and relax, and you can give rest to your thigh muscle. Or the thigh muscle can go in fatigue, no problem. Automatically you have to take a rest. But heart muscles don't have this liberty. They cannot go into fatigue. Heart muscles always require constant supply of oxygen, and oxygen comes through the oxygenated blood, which comes through arteries. What are those arteries? Coronary arteries and their branches. The coronary arteries, how many coronary arteries? 2. And they have many branches, the ascending branch, the descending branch. Those branches supply oxygenated blood to different parts of the heart. If these arteries, they got some plaque, matlab, some deposits inside the wall, then what happens? The lumen is decreased. Problem, little bit, not a big problem. But if the lumen decreases more than 75%, then what happens? Then the blood supply to the heart muscle decrease considerably, and your heart shows some symptoms. The heart start paining, chest start paining. You will say, chest में pain हो रहा, यहाँ पे हो रहा, ये यहाँ पे, going back. Come down. हाथ में आ गया. The pain start coming on the chest. This indicates that those deposits have actually blocked the circulation, blocked the diameter more than 75%. What is these deposits? First of all, what is this chest pain known as? The chest pain is known as, what did you say? Yes, angina pectoris. Angina pectoris. Why it occurs? Not enough blood go to the heart. Why not enough blood go to the heart? Deposits. What deposit? C2F2. What deposit? C2F2. What is C2F2? 2C and 2F. Cholesterol, calcium, 2F. Fats, fibers. Fats, fibers, cholesterol, calcium, C2F2. You must be thinking, sir, fats and cholesterol, aren't they same? No, they are not same. They belong to the same category called lipids. But fats, matlab, triglycerides, esters. They are esters of fatty acid and glycerol. When an organic acid and glycerol, they form a joint or a bond that is called ester bond, and the compounds are called esters. So triglyceride is an ester. 3 fatty acid, 1 glycerol. And what cholesterol is? Cholesterol is a pentacyclic compound. It's a pentacyclic compound. It has an alcohol group. The C, what's the name? Cholesterol, sterol, all, alcohol. So they belong to the lipid category, but they are two different compounds, fats and cholesterol. They deposit inside the arteries. What that condition known as? That condition is called coronary artery disease. Oh, any other name to that? Yes. What is that name? Atherosclerosis. Atherosclerosis. But one day, the day is very bad. What happens? Already the blood supply is compromised, but there is a clot formed inside the blood vessel. This is very, 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 very obvious. People having high risk factors, people with high blood pressure, lot of deposits in the arteries, other bad habits like smoking, alcohol, anxiety, or some genetics that also play a role. What happens? The blood clots inside the arteries. The clot go and then just get lodged in those coronary arteries, and they block the blood supply completely. When the blood supply is blocked completely, okay, then that part of the muscle goes die completely. There is a irreversible damage to the heart muscle. When this heart muscle, a part of the heart muscle dies, it feels like there is an attack on the heart. The person will feel the same very excruciating chest pain. He will fall down, he can become unconscious, and he can die also. This is called heart attack. What is happening? The muscle of the heart dies. Why? Because of the stopping in the blood supply. Because the muscle of the heart dies or irreversibly damaged, this condition is also known as myocardial infarction. So, bachcho, myocardial infarction is also called heart attack. Heart attack is also called myocardial infarction. HAMI, H-A-M-I. Heart attack is M-I, myocardial infarction. Heart attack, myocardial infarction. Why? Because of complete blockage. And how the beginning start? The beginning start by deposition in the coronary arteries, which is called coronary artery disease. What is the alternate name of that? Atherosclerosis. Okay, but so far. Okay, now one day what happens that the heartbeat, now I'm saying the beat is because of that nodal tissue. Sometimes the nodal tissue switches off completely. We don't know. I mean, it can happen at any time. Sometimes even my iPhone switches off by itself. Same thing. Sometimes this nodal tissue stops generating action potential all of a sudden. Reasons can be X, Y, Z. We don't know. We can say this, that, all those are assumptions. But when the nodal tissue stops sending action potential, what will happen? The heartbeat stops completely. And this is called cardiac arrest. Cardiac arrest. Heart stop beating altogether. Cardiac arrest. So you have heard atherosclerosis, coronary artery disease. You have heard the plaque made up of F2C2. You have also heard angina pectoris. You know what is heart attack. You know what is heart failure. You know what is a myocardial infarction, another name of heart attack. You know cardiac arrest. The last thing that you should know is congestive heart failure, or simply called heart failure. Congestive heart failure, or simply called heart failure. What is heart failure? Heart failure is a chronic disease. It is when the heart is not beating enough. Depending upon the electrolyte balance and the pH of the blood. What are the conditions? The pH of the blood. If the pH of the blood is high, okay, then something is being absorbed. Bicarbonates are reabsorbed. If the water in the blood is less, then water and NaCl. Actually, to absorb water, NaCl is the key. So if you want water, you just absorb NaCl. Water will come behind NaCl. Okay, and this water reabsorption in the DCT depends on which hormone? Problem? Okay. Which hormone? It is aldosterone. Okay, NaCl is reabsorbed by aldosterone. So aldosterone help in the reabsorption of NaCl and water in the DCT. After that, you have the collecting ducts. And what all are reabsorbed in the collecting ducts? Water. Water can be reabsorbed. Urea can be reabsorbed. Chudandi. Urea and water both can be reabsorbed. Malli. You can see again. Urea and water are reabsorbed. So here, the amount of water that can be reabsorbed depends on how much you have the ADH, the hormone called antidiuretic hormone. If you have more ADH, more water reabsorbed. If you have less ADH, less water reabsorbed. And a small amount of urea is reabsorbed in the collecting duct. These are all tubular reabsorption. Now coming to tubular secretion. In the PCT, what all are secreted? You have the potassium, the ammonia, okay? They are secreted in the PCT. What are secreted? Just I want to make small correction here. But I just want to make a small correction in the diagram. Please check. I hope in your diagram this mistake is not there. I am searching for my marker. I'll do this correction. Don't worry. Got it. Marker. I think a lot of cluttering is happening because of that, there is a little lag here, but please correct this. This potassium is not secreted in the PCT. This line has been removed from the NCERT. The secretion of potassium occurs only in the distal part of the tubule, which is in the DCT. Remember that this is exchanged with the NaCl or Na. There is a sodium and potassium exchanger. So the amount of sodium reabsorbed, the same amount potassium secreted. Under the influence of aldosterone, there is no secretion of potassium in the PCT. Some of your NCERT have written that even in the NCERT, it will be there. Some of you, those who are using the new version, you don't have this potassium. In the theory, this is being removed. In the diagram, already it is not there. If you see your diagram in your NCERT book, you will not find the potassium, you will only find ammonia and hydrogen ions. So once again, I think now it is clear. Ammonia and hydrogen ions in the PCT. Secretion of urea in the thin segment. Secretion of potassium, ammonia and hydrogen ions in the, again. Ammonia is because, see, actually, we have very small amount of ammonia. Although in the theory, it is mentioned. No doubt, in the theory it is mentioned. But practically, the amount of ammonia, so what all ammonia secretion is required, it can be done in the PCT only. In the DCT, the secretion is only of K plus ion and H plus ion. You can see the diagram, and the diagram is given like this. I have just removed some of the things, okay? When they come again, you will realize once again what all I have removed. Okay, beta? And you can see that what all are being, secreted in the collecting duct, again, H plus ion and K plus ion. Why the secretion? Why? To maintain pH and why the secretion? To maintain pH and electrolyte balance of the blood. This is the complete urine formation. Just go through this diagram. I said that, this is little correction which is done in the new NCERT book. This is already there. So they will appear. One thing will appear here, one thing will appear here. Chudandi. See magic. Okay. So what you have to do in your diagram, I know. So your books are not showing in your diagram, it is not there. But if it is given in the chapter, in the theory part, please make this correction, bachcho. Please make this correction. The old NCERT writes about the potassium secretion in the PCT. Remember, there is no potassium secretion occurring in the PCT, and there is no ammonia secretion occurring in the DCT. Okay, Bacho, you have any doubt here? The amount of glomerular filtration rate is 125 ml in 1 minute. In 1 day, how much? 180 liters. Just multiply 125 by 1440. 1440, yeah. The factor is 1440. Okay, bacho, right. 99% filtrate has been reabsorbed in the PCT only. So the amount of urine formed in 1 day is 1 to 1.5 liters. The amount of filtration is 180 liter. But you will find that more than 99% of it is being reabsorbed. So the urine formation is only about 1 to 1.5 liters. But so now this is a very, very important place here. This diagram is very, very important to understand this diagram. Okay, what I discuss? I'm asking you some question. I hope you can answer. However, I will also give the answer my side, but I'm expecting that as you are answering in the class. Question number 1: in which part of the nephron minimum reabsorption occurs? Answer: loop of Henle. Which segment of loop of Henle? The ascending limb of loop of Henle. Minimum reabsorption occurs. Question number 2. Which part of the nephron conditional reabsorption occurs? Conditional reabsorption. Answer is DCT. Very good. DCT. DCT. Conditional reabsorption occurs. Right. Okay. Now, which process is required for maintaining the pH and electrolyte balance of the blood? Answer is tubular secretion. Next question. Potassium secretion occurs in the proximal part of the tubule or distal part of the tubule? Answer: distal part of the tubule, mainly in the DCT. Last question. In which part of the nephron urea is reabsorbed? Urea. I'm asking as per your NCERT diagram. Which part of the nephron small amount of urea is reabsorbed? Come on. Yes, I'm getting your answer. You're writing the answers. I really like that. So you are still answering the DCT, which was the previous question. The last question which I asked, which part of the nephron small amount of urea is reabsorbed? And the answer is CD, collecting duct. Very good. So, bacha, urea is reabsorbed in the small amount of urea is reabsorbed in the collecting duct. It is being secreted back into the thin segment, and again it comes, and so it maintains the NaCl and urea in the interstitial fluid. Let's be fast here in this chapter. See the PCT. The descending limb is only permeable to water. The ascending limb is impermeable to water and only permeable to salts. See, the main purpose of the reabsorption in the loop of Henle, or what is the main purpose of loop of Henle? The main purpose of loop of Henle is to maintain the osmolarity in the medullary interstitial fluid. Question: what maintains the osmolarity? What are those two things? Number 1, yes, NaCl. Number 2, yes, urea. They both of them maintain the osmolarity in the medullary interstitial fluid. Site of action of hormones. Where is the ADH is working? I tell you, the site of action of ADH hormone. Let me take out the marker. Site of action of ADH. Where is the marker gone? Mainly in the collecting duct and distal part of the DCT. Mainly in the collecting duct and distal part of DCT. Where is the distal part? This part. This part and this part. The ADHX. Where is the hormone aldosterone X? The aldosterone X in the distal part of the tubule, which is in the DCT only. ठीक है बेटा. Please come back. Yeah. I know बच्चों तुम्हारी रैम बहुत कम है. छोटा बेबी होता है ना, उसकी नोजी बहती है. System, I was saying to you that the medulla is always salty, and not only salty, saltier, saltiest. What I am saying, I'll tell you, just give me a sec to reopen that page. Yeah. ये पूरा सिस्टम ही हो गया ब्रो. Okay, so you have cortex and the medulla. The medulla is represented only by these pyramids. If I take this pyramid, I am showing a pyramid to you. This is a pyramid, okay? A medullary pyramid. Everywhere, the osmolarity in the tissues is 300 milliosmol per liter. Here how much? 300. Here how much? Same, like cortex, 300. It is just the extension of cortex. It is called cortical extensions. In the medulla, renal columns, yeah, columns of Burton. Renal columns, yeah, columns of Burton. NCERT writes Bertini. Okay, let's call it columns of Bertini. But this is medulla. Always, whether you take fluid too much or you don't take fluid enough, always there is, this area is very, very salty. Lot of salts, lot of, like NaCl. And if NaCl is not there, then the other will be there, urea. Both, almost we can say, NaCl and urea are keeping it very, very osmolar. In fact, as you go deep inside, the osmolarity is rising. So if it is salty here, it is saltier. And it is saltiest. Saltiest. If you go deep inside the medulla, the osmolarity starts from 300, then 4, 5, 6, 7, 8, 9, 10, 11, 12. Tip of the medulla, you have about 1200 milliosmol per liter. In the cortex, you have only 300. At the corticomedullary junction, 300. then 350, 400, like that, and it is going down. It is getting more and more saltier, more and more NaCl and urea can be found there, concentrated. Now this is there that we have to understand, and in any condition, whether you are taking water enough or not, there is a lot of NaCl, and how this is maintained? This is maintained by this countercurrent system. How this countercurrent system operates? See, there are two components of the countercurrent system. One is and one is called multiplier. Or who is countercurrent multiplier? This is countercurrent multiplier. And who is countercurrent exchanger? This is countercurrent exchanger. What is this? Loop of Henle. What is this? Vasa recta. The vasa recta, this is a long, straight, thin-walled blood vessel going deep inside the medulla and again coming back. So they are side by side to the loop of Henle. What is countercurrent? Countercurrent is opposite flow. But what is being flowing oppositely? Bacha, the fluid here is flowing oppositely. Any other countercurrent? Yes. The blood here is flowing opposite. It goes down in the descending limb, and in the ascending limb it goes up. The filtrate goes down in the descending limb and ascends up in the ascending limb. So altogether, how many countercurrent? Can you think of the number of countercurrent operating here? If you say 2, I will say absolutely correct answer. There is a countercurrent here and there is a countercurrent here. Remember, there are two countercurrent. One is maintained between the blood and one is between the filtrate. Don't say 3. The countercurrent does not mean that the blood and the filtrate, they are showing countercurrent. No, that has no physiological importance. So how many countercurrent here? One here and one here. So the descending limb is only permeable to water, ascending limb only permeable to salt, and because of this differential permeability and also because of the active reabsorption in the thick segment, there is collection of NaCl in the medulla. Now this NaCl, which is being reabsorbed by the ascending limb, is being exchanged by the descending portion of vasa recta, because when the blood is going down, it takes all the NaCl that is being reabsorbed by the ascending limb. The ascending limb saying, bro, what are you doing, bro? I am spending my energy cell located in the afferent arteriole. In the wall of afferent arteriole, there are thick muscular cell, the smooth muscle of the arteriole, they become modified and they are called the JG cell. And the moment they find that the blood pressure is low, the JG cells are activated and they release something called renin, where? In the blood. This hormone renin, it is actually an enzyme, but it is just working like a hormone. It's an enzyme. Renin, R-E-N-I-N. Renin is R-E-N-I-N, not R-E-N-N-I-N. That renin is stomach renin, curdling of milk. This is R-E-N-I-N. How many N are there in the kidney? 1. So if you have one renin, one N in the renin, it is a kidney renin. This hormone renin converts a plasma protein angiotensinogen to angiotensin first. Ultimately, angiotensin first is converted to angiotensin second. Both are active. Angiotensinogen is inactive, angiotensin is active. But the second one is more powerful than the first one. However, both can work. What they can do? Actually, they can do two important things. Number one, see the name, angiotensin. They can also do vasoconstriction. As a result, they can increase the blood pressure. Same like the vasopressin, it can increase the blood pressure by vasoconstriction. Angiotensin 2 or angiotensin itself can also cause vasoconstriction and increase the blood pressure. And number 2, angiotensin can also stimulate adrenal cortex to release which hormone? Angiotensin 2 can stimulate adrenal cortex to release which hormone? Okay, just tell me, is it glucocorticoid or mineralocorticoid or sex corticoid? Gluco, mineralo, sex. Which one? You are right. It is mineralocorticoid. Do you know the name of that hormone? The name begins with A, L. Yes, aldosterone, aldosterone. And where is this aldosterone working? Just few minutes back, I told you the aldosterone work in the distal part of the tubule in causing more reabsorption of Na and secretion of K+. Okay, so the NaCl is reabsorbed because of aldosterone, and when NaCl is reabsorbed, water is also reabsorbed, and when water is reabsorbed, the blood gets enough hydration, the blood gets its water back, and when the blood gets water, its volume swells up. And when the blood volume increases, the pressure increases. And when the blood pressure increases, the GFR again increases. So both ADH and renin, angiotensin, aldosterone system can increase the GFR, increase the blood pressure, but the time when they do that, that is little different. For example, when you are sweating very, very badly, you are not taking water at that time, who will come to your help? Who? Think. When you are sweating very badly and not taking enough water, or there is vomiting, diarrhea, dehydration, who will come to your help? ADH. Yes. And sometimes if the blood pressure becomes low, then who will come to your help? It is the renin, angiotensin, aldosterone system, RAS. So RAS increases blood pressure. So if I break them, then if I ask which of them can increase blood pressure, well, number one, renin, renin. Number two, angiotensin. Number three, aldosterone. Number four, ADH. Number five, all of the above. Answer is all of the above. All can increase the blood pressure, but there should be some mechanism in the kidney to decrease the blood pressure. However, a hormone is released not from the kidney but from the heart. This hormone is called ANF, atrial natriuretic factor. So what all the RAS does? RAS does vasoconstriction. ANF causes vasodilation. It will decrease the pressure. RAS cause more sodium reabsorption by aldosterone. ANF will decrease the sodium reabsorption and increase the sodium excretion. When sodium excretion increases, there is a term for that. Again, when sodium excretion increases, there is a term for that. What is that? That is called natriuresis. Natriuresis. And therefore the name of the hormone is natriuretic factor. And because it is produced by the heart atria, we can call it atrial natriuretic factor. So what is natriuresis? Natrium. Natrium means sodium. Uresis, that is more sodium excretion in the urine. Can you tell me what is diuresis? Diuresis. Whenever the urine volume is more, when a person produces large volume of urine, obviously the urine will be dilute. When a person produces large volume of dilute urine, this is called diuresis. Diuresis, so many vowel come na. I, A, U. Just drop A from here. Just call it diuresis. Just call it diuresis, okay? So diuresis means too much of water in the urine. Okay, but also that's about the system. I hope you understood this system, and with this we come to the end of this also. This last part is important. Questions will come here, and here it is also given that the accessory organs for excretion, for example, lungs, then the skin, and also the liver. So what is being secreted by the liver? The liver produces bile, and in the bile, some things are there. What is that thing? Bile pigment. The excretory product is bile pigment. What are those? Bilirubin, biliverdin. What else? Cholesterol, degraded steroid hormones, vitamins. Okay, so you will find these things in the bile. Then sebaceous glands. In sebaceous glands, what all are being excreted? Hydrocarbons, sterols, waxes. Then sweat glands, NaCl, urea, very small amount, water, lactic acid, and lungs. Lungs remove carbon dioxide and significant amount of water. Every time when we exhale, the expired air is humid, and it is, we are eliminating or removing water through expiration also. My dear children, I hope this is clear to every one of you. And the next topic is muscular system or movement and locomotion. Movement and locomotion. Okay. So now prepare yourself for this topic, movement and locomotion. Let's begin. Movement and locomotion. Already I am locomoting. I am also moving. And I hope you are also moving. You're moving your hands, probably for writing. Okay. And some of you are also moving your tongue for talking. Not required, but yes. Okay. So movement and locomotion. Let's begin this topic. It is made up of two parts, muscular system and skeletal system. So in the beginning, we have got some basic information about the type of movement, amoeboid movement, okay? And then you have got different type of movement like ciliary movement and flagellar movement, okay? Then you have got the muscles. So muscles, they are contractile tissue, and the properties of muscles are, so what are the properties of muscle? C triple E. Number one, contractility. C for contractility. Triple E, think what are those triple E? Number one, excitability. Another E, elasticity. Another E, extensibility. Extensibility means when your one muscle contract, the other muscle, although it is relaxed, but it can be extended also. Extensibility. So C triple E, contractility, excitability means it can be depolarized. It can be excited means it can be depolarized. Depolarized means the polarity of the membrane reversed. What is the normal polarity when it is resting or not working? Outside positive, inside negative. And when it is reversed, it is called depolarized. And but remember, only when the muscle fiber becomes depolarized, then the muscle will contract. Okay, bacha, C triple E properties of muscles. All the three type of muscles, whether you have cardiac muscles, you have skeletal muscles, and smooth muscles. The smooth muscles do not show those striations, but the cardiac muscles and skeletal muscles show the striations. Stria means the stripes, okay? Now, can you tell me which of these three muscle fibers is a multinucleated fiber where you have many nuclei inside the cell? Tell me the answer. Which one is called syncytial? Yes, syncytial. Syncytial means that syn means fused, cyto means cell. Many cells fuse to form a single cell having multiple nuclei. Syncytial. Arey bhaiya, was the voice not coming? I asked which of the muscle fiber is syncytial. One is a writing muscle fiber, very good. One is writing sarcoplasm. Syncytial cardiac, na beta. Cardiac muscle is only functionally syncytial. I am asking about skeletal. Yes, Venkata Saket, your answer is correct. It is skeletal muscle fiber which is really syncytial. The skeletal muscles, okay? So let me take you, just revise this. The multinucleate fibers, you can see here. I'll show the multinucleate fibers. You can see one fiber here and many nuclei inside one cell. This is a skeletal muscle. Okay, so outermost you will find this fascia. What is this? Fascia. All this yellow, all this fascia. What is this? Fascicle. This is fascicle. And what are these? Fibers. Fibers. So a fascicle is a bundle of muscle fibers. Muscle fiber ante muscle cell. Muscle cell, muscle fiber, same thing. These are the proteins that make up the muscle fibers. The proteins are, the main protein is myosin. Another protein is actin. So actin and myosin. Myosin forms a thick filament. Actin forms thin filament. Then some regulatory proteins are tropomyosin, and the main regulatory protein is troponin. My dear bachcho, I just need a 2 minutes break. Okay, for a natural call, just a 2 minutes break. Are you guys with me? Just 2 minutes break. Thank you. Okay, बच्चों. Okay. So let's. No, there is no scope of getting tired, please. No one can get tired. Whenever you feel utterly tired, this is a time to think again and think about the goal and hit again, hit hard. This is the time to evolve. When he sees you working, he never keeps anything, any hard work of anyone. He always gives much more than we deserve. But then show that we really deserve. So the time when you are totally tired, at that time, think about the goal. Goal means the end result, not the process, but the result. And then hit again, hit hard. Okay, so let's get back to this one. And here we generally talk about this sliding filament theory. The sliding filament theory. So to understand this theory, we have to understand the sarcomere, which is nothing but the unit of muscle contraction. The unit of muscle contraction is the sarcomere. The anatomical unit or the structural unit of muscle is muscle fiber. What is that? Muscle fiber. Fiber means muscle cell. And what is the unit of muscle contraction? Sarcomere. Mere means unit. Sarco matlab muscle, flesh. A sarcomere is made up starting from the Z line, Z line. Then half of the I band, full A band, half I band, again Z line. Z line, I, A, I, Z. Z, I, A, I, Z. Z you can also call Z. Okay, then I band, this is only half of the I band because you know that Z line, it bisects the I band. The I band is the light band. Light band is called I band, isotropic band, and the dark band is called anisotropic band or A band. The A band is the dark band which is in the middle. The dark band is due to the overlapping of two muscles. One is the thick filament, one is the thin filament, and the light band is only due to the thin filament which is made up of actin muscle. Okay, the actin, the muscle name is actin. Okay, I hope this structure is clear to everyone. Now you know that the thick filament is made up of myosin. Nearly 300 units of myosin make one thick filament. What is the unit of myosin called? Come on. What is the unit of myosin? Think. The unit of myosin is meromyosin. The word meromere, it means unit. So what is the unit of myosin? Meromyosin. Okay. Now meromyosin is made up of two fibers, and those two fibers at one end you will find that there is a it becomes globular like the head. Then there is a short arm, and then there is a tail. Tail, short arm, head. Well, we can see this diagram once again. So we have got the tail, short arm, and the head. The head and the short arm collectively called cross arm, and this is the tail. So cross arm can be called as can be called as the heavy meromyosin. The heavy part, the head part is the heavy part. The heavy meromyosin, and only the tail part is called the light meromyosin. Actually, why this is so? Actually, this myosin or the meromyosin is actually an enzyme. It is an enzyme, ATPase. So when they were researching on it, that where is this ATPase activity? Okay, so they found that. So they have to break the protein. They use a muscle breaking protein called a muscle breaking enzyme called trypsin. You know that trypsin is one of the enzymes produced from our pancreas also. So they use the same trypsin. So when they break this meromyosin by trypsin, the cross arm is broken by the side and the tail is broken by the side. Okay, and then they were researching, is the tail part or the light meromyosin shows the activity? No. The other part, the cross arm, which they call the heavy part of the meromyosin, that shows the activity of ATPase. I hope you understand. So, what is HMM? Heavy meromyosin. What is it? Is made up of cross arm. A cross arm is a globular head and a short arm. Now, this head has got how many active site? One is ATP binding site and one is actin binding site. ATP binding site, actin binding site. Okay, till here, all points clear? Good. Okay, then you just imagine this sarcomere and just imagine that there is a thick filament which is mainly made up of many meromyosin, and the cross arm of it are coming and they are actually taking a small angle from the main axis, and they are coming out from the main axis at regular interval. Lot of cross arm here, all around. Lot of cross arms are coming out. Okay. Now, again, think of that at the end of the cross arm, there is a head, and the head has got ATPase activity. Now, bacha, please understand that this head can form a contact, or it can join to the active site on the actin protein, thanks to a protein called troponin, which actually masks the active site on actin. It looks like a joke, na? Joke, na? Sir, troponin? You don't have so many troponin, sir. Active site, so every globular actin, G actin, has got one active site. So how many troponin you don't have that many troponin, don't worry. We have few troponin, but troponin take the help of another protein, tropomyosin. So actually all these active sites are covered by tropomyosin, and now the troponin controls the tropomyosin. So actually who is actually controlling? Troponin, with the help of tropomyosin. And what it is controlling? The masking of the active site of what? Of the actin filament, the F-actin, the thin filament. Okay, so they are masked. Even though energy is there is ATP hydrolysis, it produces energy. Still, the head part of the cross arm cannot make a join, or cannot join to the actin, because the active sites are covered. But this covering of the active site is not continuous. Okay, so whenever there is a calcium coming out into the sarcoplasm, actually in the muscle only there is a calcium storehouse. And what is that? It is a endoplasmic reticulum. At that time, you will find that the ADP and inorganic phosphate, they leave the active site, and now the ATP binding site become vacant again. Now, the moment ATP binding site becomes vacant again, there is plenty of ATP in the muscle, and a new ATP, a fresh ATP molecule will bind to the active site. Okay, so the ATP binding site. And when this ATP bind to the ATP binding site, this will again change the configuration or the structure. This will change the structure. Any problem? Any problem, bachu? Any problem? Student. One student is called. Student call. All well. यहाँ पे voice check कर. Oh, sorry.
Okay, sir. Fine.
Okay. So at that time, a new ATP bind to the ATP binding site, and this change the structure of the head. And when the structure of the head changes, the cross bridge will break. And when the cross bridge breaks, the head again come, or the cross arm again come in the docking position or the resting position. Okay, so it will again come back in the docking position. So again, it will dock, or it will again form a cross bridge, but that shows the ATP hydrolysis. That means only energy is required, and energy is obtained by ATP hydrolysis. So ATP hydrolysis This shows a cross bridge formation. Then there is a sliding, and at the sliding, the ADP and inorganic phosphate leave the ATP site, okay? And now a new ATP will bind, and simply binding of this ATP changes the structure of the head. As a result, the cross bridge will break, or the breaking of the cross bridge. ATP hydrolysis A, okay, alum ka A, alum A, ATP hydrolysis C, chutney ka C, cross bridge formation, sambar as sliding, okay, and then B, but G is breaking of the cross bridge. And what is required for breaking of the cross bridge? The cross bridge is broken when a fresh ATP just binds. I'm not saying ATP hydrolysis, I'm simply saying ATP binds. Binding of the ATP is sufficient to break the cross bridge, and again the cross arm will come in the docking position. Now this cycle continue many times. As a result, what will happen that the thin filament keep on sliding over the thick filament, and the two Z land are coming closer and closer. You can see it is going on. The 2Z land come more closer. Again, it will go on. The 2Z land will come even closer. Now you see that as the sarcomere is shortening, you'll find that the complete myofibril is also shortening. And when the myofibril is shortening, the muscle fiber, which is the unit of a muscle, which is the structural unit of a muscle, will also shorten. And when the muscle shorten, the activity or the action takes place. So, bachcho, this is the place where people are asking many doubts. Okay, then you should just see in this diagram, you have got the appendicular skeleton and the axial skeleton. So here the white is the axial skeleton and the red one is the appendicular skeleton. In the appendicular skeleton, we have all the four arms and also the girdles. The girdle and the arms in the appendicular, the vertebral column, the rib cage and the sternum. They form what is called axial skeleton. Now, axial skeleton begins with the skull. Pinna is the skull. The skull is made up of face and the cranium. The cranium is made up of 8 bones. The face is made up of 14 bones, right? The cranium is made up of 8, face 14, 14 plus 8, 22. As a result, the whole cranium, the whole skull, we can see that it is made up of 22 bones. But there are 6 more bones, in fact 7 more bones, which are associated with the skeleton of the skull. Okay. As such, if the line comes that the skull comprising of cranium and face is made up of dash bones, answer 22 bones. How many in the cranium? 8. How many in the face? 14. Okay. Now cranium. What are the bones of the cranium? Frontal. Parietal, temporal, occipital, okati, frontal, okati, temporal, parietal, 2. 2 more bones. One is ethmoid, behind is sphenoid, ethnoid is, yes, step of 8, very good. I'm happy that people are remembering the trick here. Step of 8. This is a step of 8. The skull bones, step of 8. Step, okay? Step of 8. So this is step and off. Step, sphenoid, temporal, ethmoid, parietal, O for occipital, F for frontal. Step off. 8. Total 8 bones. Okay, but these are only 6 because temporal rundu, parietal rundu. These 2 are paired, remaining are unpaired. This is what is called the skull ka step of 8. Cranium ka step of 8. In the face, total 14 bones. The unpaired bones of the face, I kept the coffee on the couch and the technician guy just sat over it, feeling sorry for him. Okay, so face made up of 14 bones. How many unpaired bones? Only 2 unpaired. And how many paired in the cranium? How many paired? 2. And how many unpaired in the face? 2. What are those 2? One is mandible and another one is vomer, mandible. Just remember these. Then the other 7 bones are, so we have 3 here, 3 here. These are the ear ossicles. And here we have a U-shaped bone, which is called hyoid. It is also associated with the skull. Okay. So in all, we have 22 plus 6 ear ossicles and 1 hyoid. So total become 29. So on our vertebral column lying 29 bones. The vertebral column is made up of how many bones? Come on, 26 bones. How many? 26 bones. Student is calling. Hello? Hello? Sorry, I'm in surgery right now. I'll make a call after 2 hours. I will call you after 2 hours. Try to recall this. Okay, so this is a frontal, parietal, temporal, occipital. Now this is the sphenoid. So only the wing part of the sphenoid can be seen here. And now you have got this one. This is the ethmoid. This one is lacrimal. So Pedda is ethmoid, Chinna is lacrimal. This is nasal. Nose ka nasal. This is zygomatic, the cheekbone. Zygomatic cheekbone. So the upper jaw, what is the upper jaw called? It is called maxillae. How many maxilla we have? Paired. All bones are paired except the vomer, which cannot be seen from outside, and the mandible, which can be seen. So this is the mandible, a single bone, the lower jaw, and this one is the hyoid. Hyoid, also called the tongue bone. Most of the tongue muscles are attached to this hyoid, and this is the occipital condyles. This is, occipital bone. This is temporal bone. This one is parietal bone, and this one is frontal bone. So this diagram is also important. You can get this diagram, and you are asked to identify these bones. So very easy, not a big task here. It's a very easy thing. Okay, I told you that a small one and large one. So this is a better diagram. You can see a large one. This is ethmoid, and the small one is the lacrimal. And the A here, the A is the sphenoid. Okay, done. Now after that, again, this is the same thing, and we'll. After that, we have the vertebral column. Already we decided. And the vertebral formula, they will give the vertebral formula to write or to identify from the given options. So we have got C7, T12, then lumbar 5, then sacral 1, all fused, and coccygeal 1, all fused. Right. So this is how we have to write. And see, this is the order. The order is also important. Don't jumble them. So cervical, thoracic, lumbar, sacral, coccygeal. This is the order of the vertebral column. Okay. After that, we have the ribs and the sternum. So how many ribs we have? We have 12 pairs of ribs. How many? 12 pairs of ribs. How many sternum we have? We have one single sternum. How many ribs? 12 pairs. The first 7 pairs of ribs are called true ribs. 8th, 9th, 10th are called false ribs. What are false ribs? 8th, 9th and 10th paired. What are the floating ribs? 11th and 12th are the floating ribs. Okay? One more.
दो
One more.
मैडम बोला
हाँ. Let me check how much alert you are. Okay. Can you tell me what are vertebrosternal ribs? Vertebrosternal. Vertebrosternal, guys, tell me. What are vertebrosternal ribs? Only we have 3 types of ribs: true, false, and floating. Vertebrosternal, true ribs. Okay, very good. What is another name of false ribs? You are very much right. This is the first 7 pairs. Yes, they are also called the true ribs. Ideally, accept this answer, correct answer. Now, what is another name of the false ribs? False ribs का दूसरा नाम बताइए. Vertebrochondral. Yes, Vaishnavi, your answer is correct. Vertebrochondral. Yes, Radhika Reddy. Yes, your answer is correct. Krishnan Janelu, correct. Vertebrochondral. And if I simply say vertebral, it means I'm talking about the floating ribs, because they only connect to the thoracic vertebra and not to the sternum at all. They are floating ribs. Okay, bacho? Now, one very important thing here: the rib is a thin, flat, bone, and you'll find that the dorsal part of the rib is attached to the vertebral column. Okay, and the rib has got 2 attachment sites on the dorsal part, the head part. Okay, so as such, there are 2 parts of the head, or we can say there are 2 heads. There are 2 heads. Okay, so if you closely see the head part, you will find that there are 2 heads actually, right? And therefore, we use a term called bicephalic. So human ribs are bicephalic. This diagram clearly shows that at the dorsal side, this is the ventral side, and this is the dorsal side. This part is the head region. In the head region, we have oca head here, right? So this attaches to one vertebral, and this attaches to the lower vertebra. Okay, so because of these 2 attachment sites, we can say that human ribs are bicephalic. Human ribs are bicephalic. This is an important one I wanted to discuss with you. This is a rib cage in colored. You can see this one, the colored one. Okay, and Bacho, I hope you have understood all about the this axial skeleton, and similarly we have the appendicular skeleton. Appendicular skeleton is made up of, we have the girdles and the limbs. Just you have to revise the name of these bones just once, okay? And as I'll be sharing this to you in the group, so you can just go through them. And if anything is not clear, you can just keep the NCERT open near you so that you can understand. Now, these are the disorders. So myasthenia gravis, it's an autoimmune disease, and it affects the neuromuscular junction. What happens at the acetylcholine sites where the acetylcholine binds the receptors, okay? Those receptors are attacked by the autoantibodies. As a result of that, there is no place where the acetylcholine can bind and can cause the muscle contraction. So slowly and slowly the muscle become weaker and weaker, and ultimately paralysis occurs. The another one is muscular dystrophy. You know that it's a genetic disorder. Muscular dystrophy, it is the X-linked recessive disease. What is that? X-linked recessive disease, muscular dystrophy. A defect is in the protein called dystrophin protein. And you know this protein very well because the gene that makes this protein is the largest gene in the human body. Yes, this is the largest gene in the human body, and this is present on which chromosome? Yes, X chromosome. Just now I said it is X-linked recessive. So because of the dystrophin defect in the dystrophin gene, the dystrophin protein is defective. As a result, there is a progressive degeneration of skeletal muscle, and this causes muscular dystrophy. Now, another thing is called tetany. Okay. Now, tetany is different from tetanus. Tetanus, the word tetanus is a disease. Tetanus is a disease caused by the bacteria. Okay. What is the name of the bacteria that causes tetanus? Clostridium tetani. Clostridium tetani. Okay. You know that whenever you get an injury and after the injury you get an injection, and you all know that injection is due to protect a person from possible tetanus. Okay, so can you tell me what is that in that injection? Are the modified toxins or the antibodies against the toxins? When you get an injection, when the doctor will give you an injection after the injury, the doctor or the compounder says, "Bhaiya, ek injection pakka le lo. No harm, just 100 rupees, that's it." Okay. Now, what do you find in that injection? Is the injection contain antibodies against the toxin or actually the modified toxin? Yes, you are right, it is antibodies. Antibodies are there because we want immediately the injection to work. And we know that if we give the passive immunization, it is instantaneous until you give the injection and the working starts. Okay, very good. So that is tetanus. But tetany is a condition, and this is usually due to some electrolyte imbalance. Which electrolyte? Calcium. Which imbalance? Hypocalcemia. What happens there? Actually, the muscle become uncontrollable. Muscle are contracting, but those contractions are not controlled by you. And what happens that whenever normally a muscle contract, it relaxes. Contract, it relaxes. But here what is happening? The muscle is contracting and do not wait for the complete relaxation, again it contracts. Doesn't wait for the relaxation, again it contracts. So the muscle goes into a state of spasm. The muscle goes into a state of spasm. Okay, so we can call that these are wild contractions. Okay, rapid spasms, wild contractions, rapid spasms. Okay, when a contraction is not followed by relaxation, that contraction can be called as a spasm, rapid, jaldi. Okay, and these contractions are not controlled by yourself. They are not controlled by the motor neurons. They are wild. And why they are occurring? Because of electrolyte imbalance. Which electrolyte? Calcium. What is that imbalance? Hypocalcemia. Okay, wild contractions, rapid spasms. Contraction not followed by complete relaxation. Okay, after that we have got the arthritis. Arthritis is inflammation of joints that can be due to antibodies, which is autoimmune disease, rheumatoid arthritis, that can be due to accumulation of uric acid crystals, that can be called as gouty arthritis. Osteoporosis, as the name indicates, it is porosis, that means the calcium content of the bone is lesser. Okay, the bone has become really brittle and very easily can be broken. It is chances of fractures are very high. Okay, this usually is age related. That means we all, whether females or males, in higher ages suffer from osteoporosis. Okay, so not only our hearing ability, not only our muscles, not only our heartbeat, other, even our bones become weaker. So every part of the body becomes weaker. And this is the reality and the truth of life. We all are happy right now because of the youth, the energy, the vigor that we have. But one day all that will be gone. And this is, of course, a law of nature. Okay, so it is an age-related disorder, and mostly it is related to estrogen. Now, you know that in females, there is a precise menopause. That means at a particular time, you will find that the monthly cycles or the menstrual cycle stop completely. This is known as menopause. And after that, what happens that there is no follicular development. And if there is no follicular development, you know that there will not be any, estrogen synthesis. So there is hypoestrogenemia. Okay, the estrogen in the body is very, very less. And because of low estrogen, you will find that there will be, the calcium in the bones is lesser. You can see this one. This is the main part of the vertebral bone, and this is ventral. This is dorsal. Ventral, dorsal. In between the two body of the vertebra, there is a cartilaginous disc. Okay, we can call this as the intervertebral disc. This can be called as intervertebral disc. Okay, bacho. And well, this is the normal disc, and this is an abnormal disc, also known as the slip disc. Okay, this is slip disc or abnormal disc. And well, bachcho, this is a beautiful picture which shows the vertebral column, and this is cervical vertebrae. And you can see here there is a small tooth-like process, and this is the second cervical vertebra called the axis vertebra, and this is the first cervical vertebra called the atlas. And because of this odontoid process, you can see there is a pivot joint here, and because of the pivot joint, the first cervical vertebra can rotate over the second. Now, on the first cervical vertebra, the occipital condyles, I mean the whole skull is attached to the first cervical vertebra. So as a result of that, if the first cervical vertebra rotates, even the complete head rotates. Okay, so this joint is a pivot joint. This is between first and the second cervical vertebra. But so this you can see here. This is what is known as the the uh, pelvic girdle. In the pelvic girdle, you know that there are two main bones that form the pelvic girdle, and these are known as the coxal bone, hip bones. Each hip bone is made up of three parts. In this diagram, you can see the three parts in different colors, and these three parts are ilium, ischium, pubis. Ilium, ischium, pubis. The bigger part is ilium. The ischium is the bottom part on which generally we sit, and we have the pubis in the anterior region. The pubis of the two bones join, and this is a cartilaginous joint, and the joint is called pubic symphysis, also called symphysis pubis, and this is a fibrocartilage. Okay, and behind on the dorsal side there is a sacrum, which is a vertebral bone. Sacrum. Okay, so this is acha. Then there is a cup-like cavity here to form the hip joint. The head of the femur articulate with this cup-like cavity. The head of the femur fit into the cup-like cavity, and this is the hip joint. Now this cup-like cavity is called acetabulum. Acetabulum. This is called acetabulum. Acetabulum. And if you closely see the acetabulum, it is made up of the three parts. Okay, you can see this part, violet part. This is the ischium. You can see the pink part, which is the pubis, and you can see the yellow part, which is the ilium. So all the three parts, they meet at the acetabulum. All the three parts of the bone meet at the acetabulum. But so with this, we have completed this chapter 2. Now we have the next chapter, which is the neural system. I know that in the neural system, they have removed the sensory organs. So the main headache part is actually being removed. And I know that there are certain places where still people have doubt, and that I am aware of. First, I will discuss those topics, and if anything is left which is still a doubt for you, then of course we can take that one too. But first, those topics which are usually people have the doubts in, right? So first part is the parts of the central nervous system, okay, or parts of the nervous system. We can say we have central nervous system and peripheral nervous system. So what are the two parts of the central nervous system? It is made up of brain and spinal cord. Fine, it's very easy still here. Okay, now peripheral nervous system, it is made up of nerves, okay, fine. Now, peripheral nervous system, is further divided into somatic and autonomic. Now, somatic autonomic is simply that in somatic we have the CNS sending signals to skeletal muscles, and autonomic means the CNS sending signals to visceral organs. Only the efferent, somatic, CNS to the skeletal or the voluntary organs, voluntary muscles, and autonomic, CNS to the visceral organs or the involuntary organs, right? Okay, fine. So only the efferent parts are there, okay, fine. Till here, I think no one has any problem, autonomic and somatic. But then comes a confusion, and that is called visceral nervous system. Now, it is a part of the peripheral nervous system where you have both the directional fibers, you have got CNS to the visceral organs plus visceral organs to the CNS. It has got both sensory वाले कौन से? From the visceral organs to the CNS, and motor from the CNS to the visceral organs. You know that there are many reflexes, like the micturition reflex, simple. Now you know that in that reflex what happened, that because of the reflex, first of all, a reflex is started whenever there is a peripheral neural stimulation. How that happens? Blood will start getting full, distension. Then a signal arises from the bladder muscle, and the signal goes to the central nervous system. This is afferent motor. This is afferent sensory. Now, in response to that, the CNS sends signals to the bladder muscles, and this is efferent or motor. As a result of that, the bladder muscles contract. And another signal it sends to the sphincter muscle. As a result of that, the sphincter muscles relax. The bladder contracts, sphincter relaxes. And as a result of that, the sphincter, okay, the internal urethral sphincter opens up. The external is a voluntary muscle, so no, it is under the voluntary control. But the internal can open up due to this reflex. Okay, so can you, if I ask you which part of the nervous system is actually controlling this reflex, and the answer is it is the visceral nervous system, because the visceral nervous system comprises whole network of nerves, fibers, plexus, ganglion, okay, ganglia, nerves, fibers, plexuses, ganglia, nerves, fibers, plexuses, that move from CNS to the visceral organs, and visceral organs to the CNS. CNS to the visceral organs, and visceral organs to the CNS. The file is not opening up. By the time you can just keep on revising with me. The visceral nervous system is a part of the peripheral nervous system, which comprises of whole network of nerves, fibers, plexus, ganglia that move in both the direction from the CNS to the visceral organ and visceral organs to the CNS. So all the visceral reflexes are actually part of the visceral nervous system, because in the autonomic nervous system there is no sensory component. Autonomic is only made up of efferent. Autonomic is only made up of efferent fibers, not the afferent fibers. No worry, I think if the file is not opening, that means the file is corrupt. Not a big deal. I can just, revise the generation and conduction of nerve impulse. This is usually a doubt in the student's mind. But if we can open the diagrams, I can explain on the diagram, which will be a little easier for us to do. Okay, well, no worries. Let me check whether any problem is there or not. PDF is opening, no worries. PPT file. PPT file also opening, not a problem. There might be a problem in that file only. Okay, so let me explain you generation and conduction of nerve impulse. Now, before that, a nerve fiber. Okay, when we say a nerve fiber, we mean actually the axonal part. When we say the muscle fiber, we mean the whole muscle cell. But the nerve fiber is actually the axon part. So, a neuron is made up of the main cell body. A neuron is made up of the cell body, and so this is cyton, and we have the fiber or the axon, the cyton and the axon. This is axon terminals, this one, this is the axon, and so these are the branches called, these branches can be called as dendrites. Now, except the axon, the long one is axon. Except the axon, there is something known as small granules. Can you name these granules? These are known as Nissl granules. Nissl granules. Where are they present? Everywhere, except the axons. Are they present in the dendrites? Yes, they are present in the dendrite. They are very much present in the cyton part, but they are not present in the axon part. Okay, so these dendrites are afferent regions or afferent zone. We can call them as the afferent zone, and then axon terminal can be called as the efferent zone. Efferent zone. Now, this axon hillock, this is called the small hill of the axon, also called axon hillock. And this axon hillock is also called trigger zone. Why is this called trigger zone? Come on. Why it is called trigger zone? Because the action potential can be triggered from this end. Okay, so at this end, if the sodium channels or a certain type of channel, forget about the sodium, potassium, certain type of channels, they just open up you will find that an action potential can be generated here. And if action potential is generated here, as the name indicates, it is a potential in action. It will not stop here. It will keep on moving, and it will keep on moving as the name action potential is. It is a potential in action, and it will go to the end of the axon. So it will, when once it starts, it is like a bullet, like it is a triggered. You just trigger a gun, and the bullet is fired, and it will only stop till that end, right? So therefore, this axon hillock can be called as the trigger zone. This can be called the trigger zone because action potential can begin from the axon hillock. Before the axon hillock, there is no concept of any action potential. Yes, of course, the membrane potentials are there, but they are not the fixed potential. Action potential is a fixed potential and also a moving potential. Here we have different grades of potential. Here we can have excitatory, postsynaptic potential, PSP, or we can have inhibitory, postsynaptic potential. Here we can have excitatory postsynaptic potential, or we can have inhibitory postsynaptic potential. And these potentials are of different grades also. These are of different grades. So not necessarily it is the action potential. Now, just try to understand what happens at the action potential. Before that, you should understand that these these neurons, these membranes are very much permeable to potassium and nearly impermeable to sodium. So when they are not doing any work during at rest, okay, at rest means there is no action, there is no work is being done. You'll find that these membranes, the axonal membranes, they are freely permeable to potassium, okay, but they are nearly impermeable to sodium. So sodium usually collect outside the cell and potassium collect inside the cell. Okay. So we can call them as a bags of potassium in the sea of sodium. Why sea? Because outside the cell there is always a fluid, and in that fluid the main cation is, which is the main cation? Sodium ion. Inside the cell the main cation? Potassium ion. Very good. Okay, sodium ion, potassium ion, these are bags of potassium in the sea of sodium. Bags of potassium in the sea of sodium. Now, there are some anionic proteins. The negatively charged proteins are also there in the exoplasm, and they can never come out of the cell. So even though they are collected inside, there is no movement across the membrane. They are large size proteins, so they don't move across the membrane. Okay, yes, some potassium can come out. Yes, no problem. Some potassium can come out, little, and some sodium can get in. But still, most of the sodium is outside and most of the potassium is inside. Okay, till here points are clear to you. So this is something that we should understand here. Okay, now what happens that whenever it is sufficiently excited, or whenever the stimulus is given, stimulus means change in the surroundings, okay, any change, maybe physical, chemical, okay, electrical, any change. If a stimulus is given, then the same membrane which was earlier impermeable to sodium become freely permeable to sodium. The membrane becomes freely permeable to sodium. And this freely matlab means that as sodium going inside, the inside of the cell is getting positive, because positive ions are getting inside and the cell is becoming positive, and more positive the cell becomes, more sodium entry occurs. More positive the cell becomes, more it becomes permeable to sodium and more sodium entry occurs. And the whole thing is started when a stimulus of sufficient intensity is applied at this, the membrane. Okay. Now, also remember that because of this unequal distribution, you will find that there is a net positive charge outside the membrane, a net positive charge outside, and a net negative charge inside. And if I use a microvoltmeter, what I use? A microvoltmeter to check the potential across the membrane, I can find that I'll use a potential here, I'll use the electrode here and an electrode here, and I use a microvoltmeter. I can feel or I can find that there is a potential difference across the membrane. A potential difference can be seen across the membrane, and this potential difference is actually a negative potential because the cell is negative from inside. You can see there is a negative, it is negative from inside. So this is a negative potential, and this negative potential is called resting membrane potential. Yes, simply resting potential. It is a negative potential because overall the cell is negative from inside and positive from outside. Overall, the cell is negative from inside and overall positive from outside. Okay, ignore all that sodium, potassium, and all this. It is net positive charge outside and the net negative charge inside. Due to all that changes, a net positive charge outside and the net negative charge inside. But because of the stimulus, the positive go inside, the inside become positive, the inside becomes positive, and now the outside becomes comparatively negative. So what has happened here? There is a reversal of polarity. There is a reversal of polarity. Mundu, it was polarized. As you can see here, there are two poles, a positive pole and negative pole. Positive pole, negative pole. Positive pole, negative pole. This is polarized. Membrane is polarized. This is also polarized but ulta polarized. This can be called as depolarized, depolarized, or this can be called as excited, depolarized, leda excited, or it can be called as excited, excited, depolarized. Now, once it becomes depolarized, then you find that there is a local current move. Okay, so because these sodium ions are very notorious ions, they keep on moving towards the negative side. The sodium ions are notorious ions. Okay, so when the sodium ions are collected inside, okay, already potassium are inside, potassium are in plenty inside, already potassium is there. Now sodium also inside, and these sodium ions are very notorious and they try to move sideways. So when the sodium ion moves sideways, there is a flow of current towards the resting side or polarized side. This is polarized, polarized. There is a flow of current towards the polarized side. Now let's call this as A and this as B. This as A and this as B. So inside, the current moves from A to B. To complete the circuit outside, to complete the circuit outside, there will be current will move from B to A. To complete the circuit, so this will move from B to A. The charges will move from B to A. Again, inside A to B, outside B to A. This is a local circuit. These are called local current circuits. Local current circuits. And because of the local circuit, sorry. Because of the local circuits, you will find that the nearby side also getting depolarized. The nearby side also become depolarized. Mundo polarized only initial part. The A was depolarized and all the B to the end is polarized. Now because of the local currents, you'll find that even the B become depolarized. Just like the B become depolarized, the C and the D and the E and the F and the G, they keep on getting depolarized. And the potential, when you check the potential, you'll find that now the potential has changed to positive, because wherever it is getting depolarized, if you check the potential, it is a positive potential, and this potential is known as action potential. But to use a microvoltmeter, let's bring the microvoltmeter from the lab. Go, anyone can go and bring the microvoltmeter from the lab. Come on, please. Let's go. माइक्रोवोल्टमीटर आ गया, ठीक है, चेक किया हमने पोटेंशियल, अब ये पॉजिटिव पोटेंशियल हो गया, बिकॉज सेल हैज बिकम पॉजिटिव फ्रॉम फॉर repolarization sodium efflux has occurred, and now there is an exchange pump, sodium potassium exchange pump. It pumps out 3 sodium out and 2 potassium in. Sodium out, potassium in, sodium out, potassium, till it again becomes the same normal rest. When it will go to another axon, do you know what is the name given now? Okay. Haji beta. Chipandi. Dendrites. So this is known as a synapse. This is a synapse. Synapses are of two types. You know that they are chemical and electrical. We know the basic difference in the two, but then from here to here is conduction. I will now write on the board what is conduction. This is called conduction. This is called conduction. Conduction. But this is called transmission. Transmission. When it changes the neuron, it is called transmission of nerve impulse. Conduction along the axon and transmission across a synapse. Conduction along the axon and transmission across the synapse. Okay, but so I hope you understand the two terms, conduction and transmission. And now the transmission is even very, very easy. For transmission, we have to understand it in a bigger diagram. For example, like this diagram can help you to understand the transmission of nerve impulse. This is the dendrite, and this is the axon terminal in a more, like elaborate form. And there are in the presynaptic knob, there are vesicles, and you'll find that vesicles are merging to the membrane of the axon terminal. As a result of that, there is these will open up. As a result of that, they will open up. Okay, I'll show here. This is exocytosis. These vesicles contain neurotransmitter. The vesicles contain neurotransmitter, and that neurotransmitter can be now released into the synaptic cleft. Okay, so this chemical is neurotransmitter, the special chemical called neurotransmitter. Here we have the neurotransmitter, and this is the release of the neurotransmitter in the synaptic cleft. Now, the same neurotransmitter receptors are found on the postsynaptic membrane. When the receptors and the neurotransmitter binds, then there is an increased sodium permeability here also. So this also become sodium permeable. So there is a rise in the permeability to sodium. Permeability to sodium. Okay, let's leave the sodium potassium. Okay, we can just say that the ion channels open up. The ion channels open up. And because of this opening of the ion channel, a new potential develops here. a new potential develops. New potential develops. Or this new potential can be called as the post-synaptic potential develops. This is the receptor potential, a post-synaptic potential. And as you know that the post-synaptic potential can be excitatory or it can be inhibitory. It can be excitatory, it can be inhibitory. This is a typical diagram of a chemical synapse. However, in electrical synapse is a little different. In electrical synapse, there is no neurotransmitter. In fact, in place of this, in an electrical synapse, the two membranes are in very close proximity. They are almost fused to each other. There are many points of fusion. And these points of fusion, you'll find that there are gap junctions. Which junction? Gap junctions. Which one? Gap junctions. And because of the gap junctions, okay, whatever the potential here is also, it will change the axon. It will be like same like conduction. The transmission is same like conduction. I'll write here the transmission is same like conduction. These are known as the gap junctions. Which one? Gap junctions. Now can you think of which one will be faster? These synapses are known as electrical synapses. Because there is no neurotransmitter, we can call them as electrical synapses. There was a chemical neurotransmitter, we used to call them as chemical synapses. So most common type of synapses are chemical synapses. However, in the brain we have some of these synapses are this type. These can be called as electrical synapses. Electrical synapses. Point number one is that they are rare, but think of, are they faster, slower, or of the same pace? Is the transmission of nerve impulse faster, slower, or at the same pace? हाँ जी बच्चों बताइए. Electrical ones will be faster. You are absolutely right. Electrical ones will be much faster. They are much faster. Okay. Here the transmission is same as conduction along an axon, and you will find this line what I just now wrote there, and also speaking right now in the NCERT book also. You are going to find this line in the NCERT book also about the electrical synapse. The postsynaptic potential can be excitatory or it can be inhibitory also in the NCERT book. However, you can find this in the chapter of structural organization. I hope guys still here points are clear to you. I don't find any other thing. I can ask you some questions just verbally. I can just ask you verbally. For example, where you are going to find a bipolar neuron. Come on, write in the chat box where you can find a bipolar neuron. On what basis? The polarity of a neuron depends. The number of axons precisely or the number of dendrites. On what basis? The polarity. Okay, bachcho. So on what basis the polarity of a neuron depends? I'll make these neurons. Okay, so the basic design. I am now going to show you the axon. As I am using a white color to show the axon, this is the axon. Can you understand what I have drawn actually? As I have used a pink color to show the axon I have shown by, the dendrites I have shown by white color, and axon I have shown by pink color. So what I am trying to show here is that no matter here you will find that the dendrite is a much bigger one. So don't get confused. What you see at one end and the other one, in this case, the size doesn't matter. It might be possible that the dendrite is bigger than that of the axon. So it might be possible. Okay, now, so you have got these 4 types. Now this is known as the, what do you call this? As unipolar. This can be called as bipolar. This can be called as multipolar. And this can be called as pseudo-unipolar. Pseudo-unipolar, because it looks like it is a single one coming out, okay? But this is not a single one, there is made up of 2 parts, as the color I have shown here. So pseudo-unipolar. Now where do you find the unipolar? The unipolar are found in the embryonic region. In the embryonic region. Where do you find the bipolar? The bipolar can be found in the retina. Where do you find the multipolar? Multipolar, most of the neuron, especially the neuron of the cerebrum. The cerebral cortex are multipolar. And where do you find this one? This is a dorsal root ganglion of a sensory neuron. I mean, a dorsal root ganglion is always of a sensory. It is a sensory one. Dorsal root ganglion of a spinal nerve. A spinal nerve. A spinal nerve is always a mixed nerve. DRG, dorsal root ganglion of a spinal nerve. Okay, so I hope you can easily do the question based on this one, and I don't find any other point. Yes, people ask about the generation and conduction of nerve impulse, transmission of nerve impulse, synaptic transmission, and also they ask about what is the difference between autonomic and the visceral nervous system. Okay, so I'll tell you the peripheral nervous system. In peripheral nervous system, you can find, you can have the somatic, okay, and here I can divide into 2 parts. I can call one as the autonomic and one as the visceral. Now in somatic, you have got the CNS to the skeletal muscles. So not a problem. Autonomic. CNS to visceral organs. Involuntary organs, not a problem. Here, CNS to visceral organs. But also visceral organs to CNS. This can be called as afferent and this can be called as efferent, both. Afferent and efferent both. Okay, bacho? So please understand that visceral nervous system is a part of the peripheral nervous system only. It comprises of a whole network of nerve fiber ganglia and plexus, which takes signal from the CNS and take them to visceral organs, and from the visceral organ sensory signals back to the CNS. And bacho, the CNS comprise of the brain and spinal cord. The brain and spinal cord and neurons, peripheral nervous system. Here a group of cell bodies. Okay, I am making a group of cell body here. We have given a name to this, and here we have a group of cell bodies and we will call it by a name. Okay, done. So this is different names we use, and therefore I want you to tell me the names here. So a group of cell bodies inside the central nervous system, we call this as the nucleus. Okay, so this is a nucleus. A group of cell bodies in the peripheral nervous system is known as ganglion. If you thought ganglion, you are absolutely right. And if you have thought about the nucleus, still you are absolutely right. The CNS and PNS. We have got in the hypothalamus several nuclei. Now you understand here what the nucleus is now. So nucleus is a group of cell bodies inside the CNS. Group of neurosecretory cell which produce hypothalamic hormone. Hypothalamic hormone regulate the synthesis and secretion of pituitary hormones. Okay, so some of them they increase the secretion of pituitary gland and some of them inhibit the secretion of pituitary gland. One example that stimulates the secretion of pituitary hormone, one of the pituitary hormone is called the gonadotropin. We have a pair of hormones from the pituitary gonadotropins. For example, we have LH and FSH. Both of them are gonadotropins. And the hypothalamus releases GnRH, which means gonadotropin releasing hormone. Under the influence of different frequencies, different pulse frequencies of gonadotropin releasing hormone, the pituitary releases either LH or FSH. Okay, inhibitory hormone, one such example is somatostatin. Somatostatin is growth hormone inhibiting hormone. What is that? Growth hormone inhibiting hormone. Somatostatin is growth hormone inhibiting hormone. So these are just one examples, but there are many more examples of releasing hormones and inhibiting hormone. They regulate wide spectrum of the body functions. As you know that the pituitary is the master endocrine gland, and actually this one is controlling the secretion of the pituitary gland. So this is master of the master. This is nana of the nana. Okay, so you understand that regulates wide spectrum of body functions. Then we talk about the pituitary gland. Pituitary gland located in a bony cavity called sella turcica. Sella turcica is in which bone? It is in the sphenoid bone, attached to hypothalamus by a stalk. So in the diagram, you can see a hypothalamus, you can see a stalk, okay, and you can see a bulb-like gland, which is the pituitary gland. The name pituitary means what? It means batani or a pea, small pea. Now pituitary is made up of two parts, anterior and posterior, and a thin part called middle pituitary. In human beings, the middle pituitary is very much reduced. Almost it become part of the almost become part of the anterior pituitary. Okay, it is just a vestigial. It is a vestigial. It is just a thin part, a vestigial part. Okay, so the anterior pituitary is also called pars distalis. The middle pituitary is called pars intermedia, and the posterior pituitary is called pars nervosa. Pars distalis, pars intermedia, and the pars nervosa. You can also see this line in the NCERT book that in humans, the pars intermedia is almost merged with the pars distalis. Once again, in humans, pars intermedia is almost merged with pars distalis. You can also find this in your NCERT book. My dear bachcho, now hypothalamus and the pituitary are connected, and the connection is the hypothalamic hormones can reach the pituitary. So the two part of the pituitary means anterior and posterior. First of all, I'll talk about the posterior pituitary. Actually, posterior pituitary is nothing but it is a neural extension of hypothalamus. What is that? What is that? A neural extension of hypothalamus. Okay, so you'll find that some neurosecretory cells, group of cells in the hypothalamus, they secrete the hormone, and inside the axon those hormones are carried and they come to the end of the axon terminal, and there they go and they affect the cells of posterior pituitary. Okay, so the hormone from hypothalamus to pars nervosa reach there through the axons axonally, through the axon axonally, whereas the hormone from hypothalamus reach the anterior pituitary with the help of the portal circulation. You can see that in the diagram also. There is a network of capillaries in the pituitary, in fact in the anterior pituitary. You also see that a network of capillaries in the hypothalamus. So a vein arises from that, and that is known as the hypophyseal portal vein. I can simply call it as a portal vein. However, it should be called as the hypophyseal portal vein. Hypophyseal, why? Because the portal vein is named on the name of the organ which it is supplying the blood. As it supplies the blood to the pars distalis, okay, we can call this as the hypophyseal. मतलब क्या हुआ? Hypophyseal means, like hypophysis means pituitary. So it is it is a vein for the portal vein for the pituitary. Hypophyseal portal vein. Hypophyseal portal vein. Okay. So please see this diagram and very closely learn this diagram. This is important, very, very important. In fact, I should say very, very important for anyone who really understands the human physiology. Now, the neurohypophysis or the posterior pituitary produces two hormones, oxytocin and vasopressin. The anterior pituitary produces 6 hormones. How many? 6. How many total? 6. Anterior pituitary produces 6 hormones, and you can remember them by the trick called fat pig. FATPIG, fat pig. F for FSH, A for ACTH, T for TSH, P for prolactin, I for ICSH, G for growth hormone or GH. Okay, in the on the screen also you can see growth hormone promote growth of the body. Prolactin act on mammary glands, stimulate growth and formation of milk. TSH act on thyroid gland, stimulate secretion of thyroid hormone. Then pars intermedia produces MSH, melanocyte stimulating hormone, secreted by pars intermedia, act on melanocyte. Melanocytes are pigment cells in the skin, and they will control the the synthesis of the melanin pigment. As a result, they can control the pigmentation of the skin. The MSH, melanocyte stimulating hormone. But please remember, this is a vestigial hormone in the human beings. This one is a vestigial hormones. It's a vestigial hormone for the human being. Okay, now the gonadotropins, there are two gonadotropins. We have the FSH and LH. Now here itself we can learn the function of both of them, FSH and LH, very, very important. Please focus, please concentrate all your attention on one point as if you are doing brain surgery. So FSH in male act on Sertoli cell and help in spermatogenesis or spermiogenesis. In female, stimulate the growth and development of ovarian follicles, as the name, follicle stimulating hormone, so it will stimulate the follicle growth. In male, FSH and androgens regulate spermatogenesis. In males, FSH along with the androgens regulate spermatogenesis. FSH also stimulates the Sertoli cell, and Sertoli cell release certain factors which help in formation of spermatozoa from the spermatids. Coming to luteinizing hormone, in male act on Leydig cell and stimulates in secretion of androgens. In male, it acts on Leydig cells. L for LH, L for Leydig cell. And they secrete testosterone or the general name androgens. In female, it induces ovulation. A very important point, it induces ovulation and also help in formation and maintenance of corpus luteum. Formation and maintenance of corpus luteum. बच्चों very, very important. Regarding oxytocin and vasopressin, you can quickly go through the functions of oxytocin and vasopressin. Oxytocin act on the smooth muscle of the body and stimulate contraction of the smooth muscle, stimulate vigorous contraction of uterine muscle at the time of childbirth, so it is also called the birth hormone, and it is also called the milk ejection hormone. Vasopressin, also called antidiuretic hormone, because it prevents diuresis by its action on kidney. What it does in the kidney? What vasopressin does in the kidney? Two functions. Number one, concentrate the urine. Number two, vasoconstriction. Increases the pressure. Increases the pressure. Just 1 second. Is my voice coming? Can you check? Please confirm the voice, bacha. This has just fallen down, so maybe the batteries have been displaced. Please confirm the voice coming. What has happened? TV. क्या हो गया? This one is YouTube. This one is YouTube.
be server problems. And also,
ये YouTube, which one is YouTube?
which one?
YouTube. आप बस कर दो, ज्वाइन अगेन कर दो. There is a server problem, बच्चों. The application is showing some trouble. I don't know when this mic and this system ended. I don't know. I was concentrating on the board and the camera.
Just now, sir. Just now.
Just now only.
No. Please send the message to your phone. WhatsApp से आप सर.
Group low.
हाँ, group. Join the YouTube sir.
Dear students, there are server issues in our application. Please join the YouTube channel. What is the name of the channel?
Ask the bosses.
उनको पता हुआ है चैनल का नाम? Please confirm if you have connected to the YouTube channel. Okay, ठीक है. So here only we can differentiate the two hormones, oxytocin and vasopressin. Already we discussed about the vasopressin. We know what it is doing. It is a hormone which prevents dehydration. It causes a concentration of urine so as it will rehydrate our blood and also increase the blood pressure and also improves our GFR. Here also we can discuss about the disorders. Few disorders to remember here: acromegaly. Acro means extremes. Megaly, megaly. That means abnormal increase in the size. Acro of the extremes of our limbs. This is due to over secretion of growth hormone, okay? But you know, when the growth hormone secretion occurs more during our initial stages before our complete height developed, that means in our teen age, up to our 18 years of age, what happened? There is an overall growth in the body size. This leads to a situation called gigantism. Gigantism, the body becomes too big. There is an abnormal body growth. But then when in the middle age, the same growth hormone over secretion occurs. Middle age means after the closure of the growth centers in the bone. You know that in the bones there are some places where the increase in the height of the bone, increase in the length of the long bones occur. After a certain age, there is a closure of that growth center. And if the growth hormone secretion becomes extra, the overall height or length of the bone does not change. But what happens that certain parts of the body overgrows, this totally disfigure the face. As if, because the jaws are overdeveloped, the jaws are protruded out. This is called gorilla face. Gorilla-like appearance, gorilla-like. Why? Because the jaws are protruded out. It leads to serious complications, and also, if it is unchecked, it can cause premature death. Please understand that acromegaly can also cause death, not only just disfiguration, but it can also cause death if it is not being controlled on time. This is a general diagram which shows how the autoregulation occurs, how any hormone can control the level of its own, its own level. We call this as this is called feedback mechanism. As you can see here, this is a negative feedback. A negative feedback means, I tell you, whenever it is marker gone. Leave it. So negative feedback means that whenever this is a complete axis, hypothalamus, pituitary, and then the target organ, maybe let us say these are the gonads. Hypothalamus produces gonadotropin releasing hormone. The pituitary gland produces the gonadotropins like LH and FSH. LH, it stimulates the Leydig cells. Target organ, testes. The Leydig cells produce androgens. If the level of androgen is high, what it will do? It will inhibit both. Number one, it can directly inhibit the hypothalamus. It can also inhibit the pituitary gland. So that what will happen? It can directly inhibit the pituitary gland. The level of the gonadotropins, which is LH, can be reduced. And also, there can be an inhibiting factor from the hypothalamus, which can also inhibit the secretion of the LH from the pituitary, which is gonadotropin inhibiting hormone. Okay, so this is how the negative, now why it is called negative feedback? Negative feedback, it is called negative feedback because it is actually causing homeostasis, which means that if the secretion is more, the result is decrease in the synthesis. But if the synthesis is less, the feedback it gives to increase its synthesis. So the cause and the effect are in opposite direction. If one thing increases, the other gonna decrease it. So this is in opposite direction, and therefore we use the term called negative feedback. For example, simple, whenever the temperature of the body is increasing, you start sweating more. What the sweating doing? The sweating is decreasing the body temperature. What was the stimulus? A rise in the body temperature. What is the total effect? Fall in the body temperature. So rise and fall, opposite direction. Hence, the thermoregulation is an example of a feedback control. The pineal gland located on the dorsal side of the forebrain. Please remember that the pineal gland, I'll tell you, this is a very important thing to keep in mind. Important means, like, people have generally, they have doubts here. The diencephalon is made up of the roof called epithalamus. Then we have got the walls called thalami and the floor called hypothalamus. Epithalamus, thalamus and hypothalamus. From the hypothalamus, a Batani-shaped gland is hanging, and this is called pituitary gland. But from the epithalamus, there is another gland which is penis-like, and this is known as the pineal gland. Pineal gland. This is pituitary gland. Pituitary. Here, this is hypothalamus. The base of the diencephalon. This complete is known as diencephalon. This is the part of the forebrain, diencephalon. Diencephalon, a part of the forebrain. A part of the forebrain called diencephalon. The diencephalon has got, this is epithalamus. Epithalamus. This is thalamus, which is a major coordinating center for sensory and motor signaling, and this one is hypothalamus. Hypothalamus. And what is this? This is pituitary gland. And what is this? This is pineal gland. So it is on the dorsal side of the diencephalon. Okay, I hope this dorsal and ventral, this idea you can understand from here. And this is known as the diocele. This cavity is called diocele, or we used to call it as the third ventricle. Third ventricle of the brain. You know that this is filled with a fluid here, and the fluid is known as cerebrospinal fluid. Which bro? Cerebro. It secretes a hormone called melatonin. It plays a very important role in the regulation of the diurnal rhythm. Diurnal matlab 1 day, 24-hour rhythm called diurnal rhythms. It also helps in maintaining the normal rhythm of sleep-wake cycle. Sleep-wake cycle. And also the normal rhythms of body temperature. Changes in the body temperature in day and night, and also the sleep-wake cycle in 24 hours. But it also influences some other factors like metabolism. It also influences pigmentation. It can influence menstrual cycle, as well as it can influence defense capabilities, which all are actually influenced by the diurnal changes. It can influence metabolism. That means sometimes some part of the day metabolism is very high, some part of the day metabolism is low. For example, in the night time the metabolism is low, and therefore people who are like mostly moving and working in the night time and eating in the night time, because of low metabolism in the night time, they will put on more weight because of night eating. Okay, pigmentation also changes. Menstrual cycles. Okay, this is again something which is dependent on the biorhythms. And defense capabilities. The parathyroid gland. Behind the thyroid gland, there is a gland known as parathyroid. Behind the thyroid, parathyroid. But first understand the thyroid gland. The thyroid gland is present in the neck region, and it is just below your thyroid cartilage. Therefore, the name thyroid gland. So there is a thyroid cartilage. I'll show the thyroid cartilage here. Thyroid cartilage, which is the Adam's apple, and just below the Adam's apple, you can see this one. Okay, so this is the Adam's apple, as from the outside looks like Adam's apple, and this one is the cricoid cartilage, and here you have, this is the semicircular rings in the trachea. Okay, so just, and here you have the epiglottis. So just here you will find this bilobed gland, called thyroid gland. Okay, thyroid gland. There are two lobes, lobe number 1, lobe number 2, connected by isthmus. The two lobes are connected by isthmus. Okay, bachcho. Now let's move further. Thyroid gland composed of stromal tissue, and it secretes a hormone. Actually, in the stroma there are follicular cells. Follicle means a group of cells, and these cells of the follicle produces a hormone known as the thyroid hormones. Iodine is a raw material required for synthesis and secretion of the thyroid hormones. Because the name, thyroid hormones are iodothyronines. They are iodothyronines. One of them is T3, triiodothyronine, and one of them is called T4, tetraiodothyronine. Triiodothyronine, tetraiodothyronine. The tetraiodothyronine is also known as thyroxine. The tetraiodothyronine is converted into triiodothyronine. The triiodothyronine is more potent than tetraiodothyronine. The function of the triiodothyronine is regulation of basal metabolic rate, formation of RBCs, regulates, they also regulate metabolism of carbohydrates, proteins, and fats. Okay, so the rate of metabolism, and also control the metabolism directly, and also maintain water and electrolyte balance in the body. It plays important role in the development of the central nervous system during the embryonic life, in the early years of the life. So people who are born even in their embryonic life, and also after their birth also, if there is hypothyroidism, they will have idiocy. Idiocy means they have subnormal IQ. Idiocy, subnormal IQ. Therefore, it is required for the development of the brain. Okay, and also it help in the cell growth, and also affect menstrual cycle. So therefore, in hypothyroidism, the menstrual cycles become irregular. Okay. Now let's talk about the the other part, that is the stroma. In the stroma, there are some cells called parafollicular cell. Why they are called parafollicular? Because they are by the side of the follicle. Para means by the side. Those parafollicular cells produce a protein hormone called TCT, thyrocalcitonin. TCT, thyrocalcitonin. So we don't call it as a thyroid hormone, because when we say thyroid hormone, we mean iodothyronine. But don't worry, thyrocalcitonin is also a hormone from the thyroid gland. If a question comes, which of the following is a protein hormone from the thyroid gland? Which of the following is a protein hormone from the thyroid gland? So we have got T3, we have got T4, we have got TCT, and we have got all of these. So the answer here is only third one. The protein hormone is TCT, thyrocalcitonin. As the name indicates, it helps in the calcium homeostasis That means if the calcium of the blood is high, it helps in reducing the blood calcium to again bring it back to normal. So these are the functions of the thyroid gland. A very, very crucial: basal metabolic rate, RBC formation. It regulates metabolism of carbohydrate, proteins and fats. It maintains water and electrolyte balance, development of the brain in the embryonic life. Therefore, in hypothyroidism, you will find that there will be cretinism, idiocy, cretinism. It also helps in the body growth. It works along with the growth hormone before puberty. Both growth hormone and thyroid hormone, both of them, they work to help in the body growth. So thyroid hormone promote both physical and mental development. If I just compare here, the growth hormone is only controlling the physical development, whereas thyroid hormone control both physical and mental. Okay, so growth hormone only physical development, only physical development, whereas the thyroid hormones, okay, they control both physical and mental, physical plus mental development. Okay, therefore in hypothyroidism there will be cretinism. In cretinism, both physical and mental retardation can be seen. Okay, bacho, and I hope this is clear to you. Now let's come to the parathyroid. The parathyroid, there are four parathyroid glands on the dorsal side. Please remember that they are on the dorsal side. As you can see in the diagram, of course, this is a diagram of the NCERT book. The four parathyroid glands are present on the back side of the thyroid gland, one pair each in the two lobes of the thyroid. So there are two lobes of thyroid, and in one lobe, two of the parathyroid, obviously, to make the body bilaterally symmetrical. It secretes a peptide hormone called parathormone or PTH. Again, PTH also helps in calcium homeostasis, which means that if the blood calcium is low, the body will release PTH to increase the blood calcium. If the blood calcium is high, the body releases TCT to decrease the blood calcium. So PTH can be called as hypercalcemic hormone, and TCT can be called as hypocalcemic hormone. PTH, hypercalcemic, and TCT, hypocalcemic hormone. Now this diagram is a very good diagram to make you understand this complete functioning of calcium homeostasis. Actually, there is a balance between the calcium of bones and in the blood. So this is a blood stream, and this is a bone, and this is the intestine, particularly the small intestine, and this is the kidney. Please focus here, and this will help you to understand one more aspect, a PYQ, which came in 2019, is based on what I'm just now going to tell you. No doubt it is out of NCERT, that's why I'm saying that. Please focus, okay? So, as you can see, the four yellow color or golden color dots, which are the parathyroid gland. Now there are two situations. Situation number one is that if the blood calcium is low, okay, you can see here the decreased blood calcium. Because of this decreased blood calcium, the parathyroid gland will produce the parathormone. Now what it happens, it will cause the bony dissolution. That means it will cause decalcification. So calcium will leave the bone and go to the blood. Okay, so calcium will leave the bone and go to the blood. It causes decalcification. The same parathormone can also work in the kidney, and in the kidney it helps in activating vitamin D. Vitamin D. So vitamin D is activated. Vitamin D is activated because of the parathormone, and now the vitamin D, activated vitamin D work in the small intestine and help in the calcium absorption, and that also goes into the blood. Okay, now one more place where the parathyroid can work is that it can decrease the calcium. It can increase the calcium reabsorption. It can increase the calcium reabsorption from the renal tubules, thereby increasing the blood calcium. It increases the calcium reabsorption. On the other hand, if there is a rise in the blood calcium, then what? Then the thyroid gland, the parafollicular cells of the thyroid gland release what is called TCT. Now TCT works opposite to it. For example, TCT will take the calcium from the blood and then deposit in the bones. It will deposit the calcium to the bones. It will make the bones more stronger by depositing calcium there. Or we can say that the bones are just like a bank. So if you have extra money, you can deposit that in the bank for the time being. So it is just a bank account. Okay, if you have extra calcium, you can just deposit in the bone. Whenever you are in need, you can take that calcium back into the blood. Okay, so I hope this is clear. The function of TCT clear and the function of PTH also clear. In PTH, please understand that it also increases calcium reabsorption from the urine. It also increases calcium reabsorption from the urine. It also helps in activating vitamin D. Activated vitamin D help in calcium reabsorption from the small intestine. Okay, beta. So this is calcium homeostasis. Calcium homeostasis. Disorders of thyroid gland. Hypothyroidism. Actually, this is easy, I think. You all can read it by yourself. Disorders are easy. Thymus, bilobed gland located between the lungs behind the sternum on the ventral side of the aorta. That means anterior to the aorta, anterior to the heart. Behind the sternum, dorsal to the sternum, and ventral to the heart. Ventral to the heart. Secrete the peptide hormone thymosin play a major role in differentiation of T lymphocytes, which provide cell-mediated immunity (CMI). It also promotes production of antibodies to provide humoral immunity or antibody-mediated immunity. In all individuals, thymus is degenerated, and therefore the immune system becomes weak. This is one of the reasons why the old individuals, there is a degradation of the body organs or the aging of the body. The aging, matlab, like we age, that means there is deterioration of the body functions. And why that is so? Because of decrease in the defense capability in the old age. And why that is so? Because thymosins are less. And why that is so? Because thymus gland degenerates in the old age. Now, this is a very important gland which is called adrenal gland. Adrenal, renal means kidney, ad means upon the kidney. You can see the beautiful picture of the adrenal gland, the cortex, the outermost region, and the medulla, the inner region. The cortex is divided into three parts, and from outside to inside, we can call it as GFR. GFR, Jonah, all are Jonah. Jonah matlab zone. So outside to inside, GFR, glomerulosa, fasciculator, reticularis. Glomerulosa, fasciculator, reticularis. Glomerulosa, glomerulus, something about the kidney, okay? It produces mineralocorticoids. Which mineralocorticoid? Aldosterone. What aldosterone does? It helps in sodium and water reabsorption. It helps in sodium and water reabsorption from the distal part of the tubule. It stimulates excretion of potassium and phosphate. A very important line, stimulate excretion of potassium and phosphate. stimulate excretion of potassium and phosphate, maintenance of electrolyte body fluid volume, electrolyte balance, body fluid volume balance, osmotic pressure, and also the blood pressure. Which hormone? Aldosterone, produced from zona glomerulosa. What is this hormone? To which group this hormone belongs to? This hormone belongs to mineralocorticoids. Which group? Mineralocorticoids. Now coming to the middle layer, zona fasciculata, it produces glucocorticoids, cortisol. Can you tell me which hormone stimulates adrenal cortex to produce the glucocorticoids? Which hormone stimulates the adrenal cortex to produce glucocorticoids? And the correct answer is ACTH. ACTH, adrenocorticotropic hormones. ACTH. Okay. Then zona reticularis. Now, this glucocorticoid or cortisol, it is also known as a stress hormone. It is also called the stress hormone. I'll just discuss with you about the stress. Stress means whenever the requirement of energy is high, this is called stress. Whenever the requirement of energy is high, we call it stress. What the stress hormone does, it stimulates gluconeogenesis, lipolysis, proteolysis. So actually when the body energy requirement increase, it can be fulfilled by increasing the blood glucose level. But then you have to understand how the blood glucose level increases. It is done by gluconeogenesis. It is done by lipolysis and proteolysis. By proteolysis, amino acids are formed. These amino acids the cells are inhibited to take this amino acid from the blood so that the amino acid will not be utilized and they will go to the liver and the liver will convert them easily into the glucose. So it inhibits cellular uptake and utilization of amino acid. It stimulates the cardiovascular system by increasing the blood pressure and also increasing the GFR. Remember, it increases the blood pressure and also increases GFR. The most important point here is anti-inflammatory reaction. Remember that cortisols are anti-inflammatory. It inhibits inflammation. Okay, cortisols are anti-inflammatory. It inhibits inflammation. It inhibits allergy. It suppresses the immune system. It suppresses the allergic response and also stimulates RBC production. It stimulates RBC production. Which other hormone stimulates RBC production? Which other hormone stimulates RBC production? Yes, you are right. Thyroid hormones. Do you know any hormone from the kidney? Erythropoietin. Erythropoietin. Any hormone from the testes? Androgens. Androgens. All these are erythropoietic hormone. Number 1, thyroxine. Number 2, cortisol. Number 3, erythropoietin. Number 4, androgens. It stimulates RBC production. The sex corticoids or the androgens, adrenal androgens, very small amount of androgenic steroids are produced from the innermost layer. It plays a role in the growth of axillary hair, axilla. Axilla means armpits, pubic hair and facial hair during puberty. The adrenal medulla is an extension of sympathetic nervous system. So beta, whenever there is a sympathetic stimulation, adrenal medulla produces catecholamines. Catecholamines. Example of catecholamines are adrenaline and noradrenaline. Adrenaline and noradrenaline. Actually, this adrenaline, this is a brand name. It is a brand name of a hormone called epinephrine. It was popular by its brand name, adrenaline. The norepinephrine and is also called noradrenaline. Actually, if you ask me, in the market you can get adrenaline injection. But if you ask them, do you have noradrenaline? He will say, huh? The pharmacist will say, huh? Because there is nothing called noradrenaline. Because the epinephrine is adrenaline, they then start calling norepinephrine as noradrenaline, and it has become popular. I'm not saying it is a mistake, no. The name has become popular. Don't know why. Also called emergency hormone or hormone of fight or flight, because these hormones are rapidly secreted to respond to stress and during emergency situations. What it does, it increases alertness, it increases pupillary dilation so that you can have more eye tunnel vision. It is called tunnel vision. You can, it will also cause fine hair to rise, piloerection. This is called goosebumps. Goosebumps. You can see small bumps on the skin. And sweating. Increase heart rate, increase the strength of ventricular contractility, increases the rate of respiration, increase blood glucose level by breakdown of glycogen. That means glycogenolysis, because glycogen is a storehouse. It is an emergency store. So it helps in the breakdown of emergency store. Remember, it is an emergency hormone and it stimulates the breakdown of lipids and proteins also. So adrenal gland is a very important gland. It's a very important gland. Okay. Now here the stress response has been shown. The adrenal gland is therefore called 4S gland. The adrenal gland can be called as 4S. The adrenal gland can be called as 4S. 4S. Okay. What are these 4S? One is salt, aldosterone. One is sugar, cortisol. One is sex, which is the androgens. And one is stress, the catecholamines. The adrenal gland is also called the 4S gland. So salt, sugar, sex, and stress. These are the 4S of adrenal gland. So whenever there is a stress of any kind, and when the body realizes that there is a danger or a stress situation, a fight or flight response is generated. All these sympathetic nerves are stimulated. The sympathetic nerves that innervate to the adrenal gland or adrenal medulla causes the release of the catecholamine hormones, particularly adrenaline. Adrenaline increasing the breathing rate, it converts glycogen to glucose, that is glycogenolysis. It increases the blood pressure, it causes dilation of pupil or pupillary dilation, increases the heart rate and slow down digestion. Remember that during fight or flight response, the body does not want to waste its energy in digestion. There is a piloerection and increased sweating. On the skin, you can find goosebumps and increased sweating. Okay? And so these two are catecholamines. Both of them are combinedly called catecholamines. Another important gland is pancreas. In the pancreas, there are two cells, alpha and beta cell, and the hormones produced by alpha and beta cell help in homeostasis of glucose. Alpha cell secrete glucagon, beta cell secrete insulin. Alpha cell glucagon, beta cell insulin. Both are peptide hormones. Glucagon is hyperglycemic hormone. Insulin is hypoglycemic hormone. Now, hyperglycemic, it can increase the blood glucose level by various ways. For example, the glucagon can, it can stimulate glycogenolysis, that is breakdown of glycogen, and also reduces cellular uptake and utilization of glucose. The beta cells, on the other hand, is hypoglycemic hormone. It works on liver cells and the fat cells, very, very important. The target cell of insulin, adipocytes and hepatocytes. Adipocytes and hepatocytes. Which cells? Adipocyte. Any other? Hepatocyte. Both of the above. It increases cellular uptake and utilization of glucose. And what is the utilization of glucose? Conversion of glucose into either utilization for energy or conversion. If it is extra, it is converted into glycogen. It stimulates rapid movement of glucose from blood to adipocytes and hepatocytes. In the adipocyte, this extra glucose is converted into fats, and in hepatocytes, either it is utilized or converted into glycogen. So therefore, whenever you eat extra calories, extra glucose, extra sugars, if it is extra, there will be release of insulin in the body. So, whenever you eat any glucose-rich diet or calorie-rich diet, there is a release of insulin in the body. And what the insulin does, insulin bring down the blood glucose level drastically. It also stimulates formation of fats. It works on the adipocytes and causes formation of fats. So therefore, you will find that the insulin can make us fatty. And how we can prevent getting fatty due to insulin? We can reduce the intake of calories, because if you eat extra calories, the extra one which we don't require will be converted to fats. And now these fats are so difficult to burn that it is almost next to impossible to burn them efficiently. The disorders related to the pancreas, diabetes mellitus. There will be hyperglycemia in diabetes mellitus. It can be due to either deficiency of insulin or due to insulin resistance. What is the meaning of insulin resistance? It means that the cells are not responding to insulin. Which cell? Adipocytes and hepatocytes. Why they are not responding? Because the receptors are not working. Okay, because the blood glucose is very high, the glucose is filtered by the kidney, and of course there is a filtration of glucose, but because the glucose is within the limits, it is completely reabsorbed in the PCT. But if it is too much, it cannot be completely reabsorbed, and the extra one will be appear in the urine. Presence of glucose in the urine is called glycosuria. Presence of ketone bodies in the urine is called ketonuria. Why ketonuria is there whenever there is diabetes mellitus? Why? Because see, ketone bodies are formed whenever the body is unable to utilize glucose. So it will try to utilize some other compounds, for example, fatty acids. As a result of that, ketone bodies are formed. So ketone bodies provide energy to the cells. The ketones are not, reabsorbed. If they are filtered, they cannot be reabsorbed and they will come in the urine. This is called ketosis. Okay, ketosis. Okay, now this extra ketones in the body will appear in the urine, and that is called ketonuria. In diabetes patients, there is both ketonuria as well as glycosuria. Ketonuria as well as glycosuria. Then bacha, heart, it produces ANF, atrial natriuretic factor. Kidney produces, the JG cells of kidney produces erythropoietin, which is a peptide hormone and help in RBC production. So erythropoiesis, the hormone that increase RBC production. Can I ask you once again? So one of them is this one only, and this one is the erythropoietin. So this one is erythropoietin, Poietin. Okay, done. Now I want some more. Number 2, I can say T3, T4. Number 3, I can say cortisol. Cortisol. Number 4, I can say androgens. Androgens. And number 5, I can say all of these. All of these. All of these. And the answer is all of these. All these 4 of them, I will write them like this so that generally we have only 4 options. So androgens. This one also, this one also, this one also, and this one also. All these hormones increases RBC production. And I'll now discuss with you mechanism of hormone action. Actually, the real mechanism is not in our syllabus. What is in our syllabus is categorization of hormone. The categorization of hormone means that which hormone belong to which category. We can divide the hormone into 2 categories. We can say which are water soluble, and the other one are fat soluble. So 2 of the categories are fat soluble. These are steroids, and number 2, iodothyronines. Iodothyronines, steroid. And water soluble hormones are number 1, we have got what we call catecholamines. And number 2, peptides. Even peptides, proteins, all. Peptides, proteins. Okay, now the steroids. 5 examples of steroids in the body are: number 1, we have got the androgens, the testosterone, the estrogens, the progesterone, the cortisol, the aldosterone. But so these are the 5 steroids. In our body, the 5 steroid hormones are androgens, estrogens, progesterone, cortisol, aldosterone. The iodothyronines are T3 and T4. The amino acid derivatives are catecholamines like epinephrine and norepinephrine, and all the remaining one, I'll say rest all are peptides. So first of all, we have categorized these hormones as water soluble and fat soluble. Now, the water soluble hormones, their receptors are present on the cell membrane because they cannot enter into the cell. So you'll find their receptors are present on the cell membrane in the water soluble. In the fat soluble hormone, they have got intracellular receptors, mostly nuclear receptors. So they have got membrane-bound receptors, and the other category we have got the intracellular or nuclear receptors. Okay, so we have got a nuclear receptor, and this one is the membrane-bound receptor. Now, I'll now discuss with you. The hormone binds to membrane-bound receptor. Now, when this hormone receptor hormone receptor complex will cause formation of a second messenger. A second messenger will cause the biochemical changes. and this will cause the physiological changes. The hormone receptor complex is present on the cell membrane. The second messengers are cyclic adenosine monophosphate, inositol, triphosphate, and calcium ions. The intracellular receptors, this is an intracellular receptor or a nuclear receptor. The hormone will come inside the cell. It will bind to the intracellular receptor, which is a motile receptor. Or if it is a nuclear receptor, it is inside the nucleus. Now, when the hormone receptor complex formed, it will then bind to the genome or the DNA. Okay, I'll write here the gene. Hormone receptor complex will bind to the gene and will modulate gene expression. It will modulate matlab change, modulate gene expression. Okay, now gene expression matlab you have what you call the transcription and translation. So it will increase transcription and translation. Transcription will form the messenger RNA, and after the translation, you have got the polypeptides, the proteins. The proteins they work as enzymes. Enzymes bring about biochemical reactions, and biochemical reactions bring about the physiological reactions. Biochemical reactions bring about physiological reactions. Okay, bachcho, so I think this is the difference of the two type of hormones. Okay, number one, like the membrane-bound receptor. After that, the first response is generation of second messenger. This bring about biochemical responses, which ultimately bring about physiological changes. Now here the hormone enter into the lipid membrane and go to bind to this one is a nuclear receptor. It will then bind to the gene part and then modulate gene expression. Gene expression is mRNA and protein, and ultimately it will affect the biochemistry, and changed biochemistry will affect the physiology. So this is the basic difference of the two. Take my words that in mechanism of hormone action, they have no other question other than this. My dear bachcho, I think this is 1 o'clock. I'm also tired now, from 7:40. I'm continuously speaking, and you're also tired because I think you have to take your meals. Now we have got two chapters, three questions each. Number one is structural organization, where you have the cockroach and frog and animal tissues. I think in cockroach, some of you have some issues. Well, I can share you the notes. And they are also in the fill in the blank format. And fill in the blank format will match up with the NCRT lines, the important NCRT lines. This is one thing. Okay. The other one is animal kingdom. Of course, we require energy and time. Means around 45 minutes for that, which I don't we have. I think you can revise these chapters, okay? And I will share with you some material to revise them. With this, we come to the end of this session. I hope whatever points I have discussed with you have gone to your head and you have retained them. And that will be evident when I will give you the question paper. In the question paper, most of the questions will be from the lines that I have spoken. It all depends how much concentrating you were. If you have concentrated, you will do those questions nicely. Of course, many of the points which you already know, but then try to maximize your score. Suppose if you are betting, what do you like? 2 runs, 1 run, 3 runs, 4 runs, 6 runs. Of course, 6 runs. I want you to hit a 6 runs. Hit a huge 6. Okay? And that will be evident when you write a test on zoology. All the very best. God bless you. Tata, bye bye. Take care. And of course, we all are together now. This session has not ended, and continuous support will be continuous. Okay, all the best. Bye bye.